Thank you very much. I might just start by saying I'm extremely fortunate for working at Waitemata, and big hands out to Guthrie. I think she's a very well-deserved awardee this year. She's stepped into the clinical education role at a time when there's been tumultuous change at Waitemata, and you've done a fantastic job, so thank you. But I'm even more privileged to work with Balaji, and Balaji has been a leader at Waitemata, and I'd echo has gone more than being a physiologist and provides care for renal patients, but also provides a high standard of leadership at Waitemata and nationally. So I think you've got two very well-deserved recipients for this year's awards. And I'm really fortunate to work with both of them. So I'm going to go slightly off-piste and talk to you about both calciphylaxis and the BEAT-CALCI study, including a little bit of information that is unpublished, but has just been submitted. Who's moving the slides? Yeah. Okay, so thank you very much. So calciphylaxis is quite a rare disease, calcific uremic arteriolopathy, also known as calciphylaxis. And it doesn't always occur in patients who have renal impairment, but it's far more common and far more frequent in patients who have end-stage renal disease. Having said that, it's a pretty rare disease. And historic data suggests that the mortality and morbidity of this condition is really high. So historic case series from the early 2000s suggested that mortality, many patients would, about 50% mortality at about 12 weeks to 6 months. Histologically, we know that patients with end-stage kidney disease have abnormalities of calcium, phosphate, and parathyroid hormone. And what appears to happen in these patients is that there's deposition of calcium with medial calcification, thickening of the blood vessels, and proliferation of blood vessels, typically in the peripheries, but for some patients, it can occur centrally. And so you get narrowed blood vessels, which form thrombus. And what do we see clinically? We start to see patients who have pain. And that pain can become plaques, and those plaques can progress to ulceration, which can become superinfected, and patients die. It's extremely painful, and it leads to infection and death. And typically it presents in the lower limbs, but occasionally you can get abdominal calciphylaxis. And I'm sure you all have seen both of those conditions. This is a pretty rare disease, and we don't know a lot about it. So some data is starting to come out from registries. And the first registry that published its data and was established was the German calciphylaxis registry. But that just provided us a point estimate of incidence. It's a 1 point in time registry, and it doesn't present a lot of information about long-term data. The Australians have established an Australian calciphylaxis registry. And I'll just let you know, I'm very happy to share these slides and keep them. And I'll give them to Balaji. So you don't need to take photos. I'm happy to share it. So the Australian calciphylaxis registry was set up by 7 centers, and they established longitudinal data. This established that there were 47 cases in those 7 centers over a period of 5 years. The mean age was about 66. Patients had an elevated BMI, about 35 mean BMI, and the majority had end-stage renal failure on hemodialysis. And about 2/3 involved the lower limb, so about 1/3 involving the abdomen. And the mortality was about 50%, 1.5 years post-diagnosis. But that, of course, didn't involve all centers. So myself and some Australian investigators have been working on an NZASRDP project. So in 2019, episodes of calciphylaxis were added to NZASRDP. And of course, you'll all know that NZASRDP, the Australia-New Zealand Dialysis and Transplant Registry, records information on every Australian and New Zealand patient who's on renal replacement therapy. So it was a voluntary add-on of data, and there was no definite diagnosis needed. It was in the investigator's opinion. And, historically, we used to say calciphylaxis used to have to take biopsies to prove it. But of course, that increases infection risk and is another invasive procedure. So for many of us, it's a clinical diagnosis. And that was what the registry used for entry of this information. So between 2019, when this information was added, in 2022, we had found that 333 patients had episodes of calciphylaxis reported. There were 23 patients who had 2 episodes. In addition to those 333 patients, there were another 16 who were reported to the registry who were pre-end-stage renal failure. And there was 1 patient who had stopped dialysis and then developed calciphylaxis. So those patients who were pre-CKD or who had a late withdrawal were not included in the data analysis. So we identified that the overall incidence of calciphylaxis was about 2.5 episodes per 1,000 patients years on renal replacement therapy. And when you look at the German data and case series data, that's probably about right. The reported incidence is about 2 to 4 per 1,000 kidney replacement years. So it kind of fits. By modality, we found that for hemodialysis patients, there were 4.5 episodes per 1,000 patient years, 4.7 per 1,000 patient years for patients who are on peritoneal dialysis, but a much lower rate in patients who are transplanted, which again fits with our clinical experience, far more likely in the end-stage population compared to the patients who are transplanted. What were the characteristics of these patients? Average age was about 63. About half were women, 64% were European, and about 58% were overweight with an elevated BMI of more than 30. Almost 2/3 of the patients had diabetes. And for patients who are on dialysis, on average, there was a median of 3.2 years before they developed the calciphylactic episode. For patients who had a kidney transplant, that period was a lot longer, median of about 6.6 years. So we looked at this cohort and compared it to the patients who didn't have calciphylaxis. And as you'd appreciate, roughly 333 who had calciphylaxis, but over 46,000 who didn't. And we've noticed a few interesting features. So mean age was about 65, but this was younger than the average age of a patient on renal replacement therapy. About 50% were women, but far more men are on renal replacement therapy. So the female gender was a risk factor for developing calciphylaxis. And interestingly, calciphylaxis has not been reported to occur more frequently in ethnicities overseas, but we identified that New Zealand Maori had a far increased rate of calciphylaxis compared to other ethnicities. So if you have a look here, you can see that the incidence in Maori is much greater than patients who are on renal replacement therapy. So that's the first report of ethnicity or specific ethnicities having an increased risk. About half of our patients have diabetes going on to renal replacement, or about 30 to 40% have diabetes as their primary renal disease. But diabetes and cardiovascular disease did appear to be a risk factor for calciphylaxis. And in addition, an elevated body mass index. And in addition, hemodialysis did seem to carry an increased risk. How did this group do in a modern cohort? We found once again the survival was extremely poor. So this is a Kaplan-Meier curve which shows your survival. 100% of people are alive at the start of the study. And I think you can see at 1 year, about 50% of these patients had died. So the mortality for this condition is extremely poor. And this shows the hazard ratio of survival. So your risk of death is almost 6 times greater when we adjust for all factors if you develop calciphylaxis. So your risk of dying is increased 6 times compared to the the normal dialysis population within 1 year of diagnosis of calciphylaxis. So this study really highlights that the risks of a slightly younger age population, female, diabetics with elevated BMI and underlying cardiovascular disease as being risk factors for developing calciphylaxis. And for the first time, we've identified a specific ethnic group, New Zealand Maori, who seem to have an increased risk. And also identifying really very high mortality amongst this group. So what do you do if you have calciphylaxis? What is the treatment? So this is the meta-analysis of cohort studies. And I've got to say this meta-analysis is about 3 or 4 years out of date. But really what it highlights is that studies which have looked at sodium thiosulfate do not show any reduction in terms of risk of death. So risk of death is 0.89, but it crosses across 0.71 to 1.12. So there's no reduction in reported rate of death or mortality with use of sodium thiosulfate. And you see the same thing when you look at parathyroidectomy, when you look at use of cinacalcet, when you look at use of hyperbaric oxygen, or if you look at the use of bisphosphonates. We don't have any trial data to say what we should do. Sodium thiosulfate, I use it. It's been my standard of practice. I know that people do it. It's extremely expensive. The cost of sodium thiosulfate is about $26,000 for a 6-month course. It takes time and gives the patient side effects. So this is the updated meta-analysis published in April of this year. And guess what? No benefit from sodium thiosulfate from the meta-analysis of trials. So nothing in 2019, nothing in 2023. So what are we trying to do about it? This is a rare condition, and recruiting patients and putting them into a trial is really super challenging. And 3 randomized controlled trials have been attempted for sodium thiosulfate. And guess what? None of them have been completed. We have not been able to recruit patients to achieve sufficiently powered trials. And there is one trial of a calcification inhibitor underway in the US and Europe, and it's trying to recruit 66 patients. So the number of patients that these trials are getting is pretty small. So what do people do? This is a online survey which has looked at clinical practice of what nephrologists do. And most of us would give sodium thiosulfate. About 30% would use vitamin K. About 25% will use cinacalcet. Very few people will use magnesium, but magnesium is popular in Europe. Most would stop warfarin, right? And I think that's probably standard of care. And most would stop giving activated vitamin D, cholecalciferol, and give calcium supplementation. Try and let that drift down, and but try and keep the calcium in a normal range. And for some patients, we would try and intensify dialysis, noting that even getting patients into standard 3 sessions a week is very challenging in some centers. So You know, that's super hard. So you can see we do a lot of things, but we're not really sure what we do, and there's not very much evidence. So we've got this condition of calciphylaxis that has high mortality, that we don't have any good standardized methods to assess calciphylaxis, and there are a wide range of possible treatments that we're not really sure actually helps patients. So there's an urgent need to try and expand this information base for therapy. And so that's led to the Beat Calci study, which is better evidence for calciphylaxis. And this is an investigator-initiated trial. It's not run by a drug company. It's run by people who are interested in trying to expand our evidence base and try and help our patients. And it's a slightly unusual design in that it's an adaptive trial. And I'll touch base a little bit about an adaptive platform design. So the goal of this trial is really to try and get as good quality evidence in a range of interventions which can be used to treat patients who have end-stage kidney disease who've got calciphylaxis. And this trial, rather than saying, okay, we've got this drug or this treatment, and we want to compare this drug or this treatment to standard of care, is actually accepting multiple domains. So we accept that there's a wide range of clinical practice, and not all practitioners may want to try a therapy and may have different standards of practice. So this is an adaptive trial in that we'll accept that there are multiple domains of therapy which can be used with the goal of trying to improve outcomes within patients with calciphylaxis. So this trial allows multiple domains. What's a domain? So a domain may be pharmacotherapy. And you would say that pharmacotherapy includes sodium thiosulfate, vitamin K, and magnesium. They're all drugs which we can use to try and treat calciphylaxis. Okay, what's another domain? Another domain might be our dialyzer. Can the type of dialyzer that we use influence an outcome for patients who have calciphylaxis? What's another type of domain? Hyperbaric oxygen. Hyperbaric oxygen, you remember, is where you'll go into a pressure chamber and have an increased pressure of oxygen, and perhaps having increased oxygen might improve oxygenation to tissues and improve wound healing. So you can see that there are different types of domains which may be used to improve calciphylaxis outcomes. And this adaptive platform doesn't say, look, I'm going to use one treatment, I'm going to run for 3 or 4 years and test that one treatment. It will allow multiple treatments to be coming on board as part of the design of the trial. And that's really what that slide highlights. So we'd use multiple domains, and maybe this is sodium thiosulfate, and sodium thiosulfate shows a benefit, so it becomes standard of care, and then we continue with other interventions. So we try different therapies to say this works, or in fact, we try investigational agent 1, which doesn't work, and then we disseminate that information and stop using it. So it allows us just to keep going with that goal of trying to improve therapies for calciphylaxis. So we've got a better probability of getting a good result. We've got a structure which says we're trying to treat, we're interested in calciphylaxis, we want to get good outcomes, and we can use multiple different treatments. And say my hospital is super interested in a dialyzer domain, but another hospital isn't. They can still put people into this trial in a pharmacotherapy domain. So we can use different domains. And it removes this concept of competing trials. You can go into the trial from just the dialyzer domain or the pharmacotherapy domain or multiple domains. So as part of this trial, we've got a global protocol, but we also have a specific protocol for the domain. So for the pharmacotherapy domain, there's a specific protocol. For the dialyzer domain, there's a specific protocol. For hyperbaric oxygen, we've got a specific protocol. And also we have a country-specific protocol, because what I might do in New Zealand will be different to Australia and different to other countries. So we want to accept that and have good regulation. So for this trial, patients can be randomized if they'll accept one or multiple interventions. And they would be randomized for each of those interventions. So for instance, Hawke's Bay might say, we'll only do pharmacotherapy. Waitemata might say, we'll only do dialysis domain. Auckland might say, we'll do both of them. So if you're in two domains, you might be randomized to each by coin toss to each of those. So who goes in? If you're over the age of 18 and you're currently receiving dialysis and eligible to move to hemo. So we have made the decision that if you remain on peritoneal dialysis, you wouldn't be part of the trial. And I think, again, and that reflects standard of care. I think most patients would transition, most nephrologists would be pushing their patients to transition from PD to hemodialysis who have calciphylaxis. If the lesion has been present for less than 10 weeks and the patient and the team are willing to recruit to at least one domain, then the patient's eligible to be part of the trial. And the endpoint is change in the ulcer over about a 12-week period. That's our primary endpoint. So there's a beat-calci specific scale which has been developed, and historically there hasn't been any good outcomes or reported outcome data for these lesions. And basically, if the lesion gets entirely better, or if you die, that's the range in the scale. So we've got a couple of domains that are up and running, with the third domain, hyperbaric oxygen, coming on board. The first domain is a dialyzer membrane domain. And we did think very hard about whether we could actually have a dialysis dose domain, whether we could have, say, 12.5 to 15 hours versus 18 hours. But actually, when we surveyed all the people involved, most of them said, look, we just do not have the capacity to increase hours in the context of a trial. So we have landed on a dialyzer membrane domain, and this utilizes the mid-cutoff dialyzer versus hemodialysis using high flux. So not HDF, HD using high flux. The overall dialysis prescription remains under the team. So we say, okay, you're randomized to the mid-cutoff dialyzer or a high flux dialyzer, but actually your hours, your target weight, your dialysate, that's all the component of the dialysis prescribing team. So what happens? You'll be either randomized to the mid-cutoff dialyzer or hemodialysis. And because this is a pretty painful intervention and a painful and debilitating disease, we say if you haven't responded by 12 weeks, if your wound isn't improving, then everyone goes into the mid-cutoff dialyzer, considering that that gives you a little bit more dose. And we follow patients out to 26 weeks, noting that the primary outcome is at 12 weeks. And basically anyone who's happy to have the dialysis membrane and the patient's happy can be involved. Now, in my head, probably mid-cutoff is the same as HDF. So if you have HDF and your team wants you to have HDF, then you can't go in this domain. The other domain that we have up and running is the pharmacotherapy domain. And we're trying to test three drugs as part of this study: sodium thiosulfate, vitamin K, and magnesium. So at the start of the trial, if the patient and the team are happy for them to go into the study, the patient will be randomized to placebo, getting no study drug, or sodium thiosulfate, or vitamin K, or magnesium. The bell's run. I'm going to run over time. I'm sorry. So you would only get, you'd have a 25% chance of having no active drug, a 25% chance of having magnesium, 25% chance of getting sodium thiosulfate, and a 25% chance of getting vitamin K. Because we're not sure if one of these medicines work. And at 4 weeks, we do an assessment as to how people are feeling. Is the wound getting better? Is the pain improving? If the wound's getting better and the pain's improving, the patient continues along with that therapy. However, if the patient is getting worse, then they have a new drug added. So at 4 weeks, if the patient's getting worse, every patient will have at least one investigational drug. So if you're on no drug, you might have one of those 3 other drugs. If you're on sodium thiosulfate, you've had it for 4 weeks and you're not getting better, you will have a second active drug added. So, and that's to recognize the mortality is really high and we don't want our patients to miss out if they're getting worse. Okay. And then at 12 weeks, we do the same. So if at 12 weeks, you're still getting worse, we actually say we're going to give you every potentially active drug, and we follow the patients out to 26 weeks. So basically, again, anyone can go in this unless they've got an allergy to one of the drugs or the physician is not happy for them to continue, or if they've got an active malignancy or breastfeeding. So that's the follow-up, and we follow patients to 26 weeks, but then there's passive follow-up. So we would do 6 monthly follow-ups after that. So they're not in the trial, but we just want to see, are they alive, are they dead, how they're doing? And we follow that to 5 years. Where are we in terms of the trial? We've got health and disability multi-regional ethics approval. The first site was up and running in Australia. The first New Zealand site was activated, and at the start of this year, the first New Zealand patient was enrolled in the trial. In New Zealand, we've now got 4 sites activated, another couple in startup, and we've recruited 5 patients. So look, the numbers are super small. In Australia, they've got 8 sites and 6 participants recruited. So the numbers are small, and you'll remember that for all of these trials, they failed because it was super challenging to recruit. So we're at the start, and we're hoping that the participant numbers will progressively increase. There's also negotiations underway with the UK and Canada and other countries to come on board with the study. So thank you, and I'd just like to open up the floor to see if there are any questions. So the question is, why sodium thiosulfate and why not other chelating agents? So I think that's probably on a historic basis that we've got the most awareness of sodium thiosulfate. It was reported and has become probably standard of care. But for many people believe I cannot not give sodium thiosulfate. So it's probably a practice question. You're right, there are a number of other chelating agents and a number of other agents targeting vascular calcification, but I don't think they've got the same coverage. And the value of this platform may be to say, look, we've got this novel agent, the preliminary data shows it's super good, and we could enter it as a new pharmacotherapy agent because of the design of the trial, right? Because it's an adaptive platform design, it can adapt to a novel agent being added. Say that again. Yeah. So there are some suggestions that high-dose erythropoietin and high-dose iron can contribute to vascular calcification. Is that what you're asking? Yes.
That's how for calcium. It's also an alternative. It's used in the finite chelating for something it's used in that. So why not ferrous sulfate in place of?
I don't think there's a large evidence base pro or against ferrous sulfate in this setting. Got a question from Frederick, I think.
Janak, when you mentioned when someone is making no progress with one drug, you're going to add the second one. Is there an order of priority because you are left with two? Which one?
It'll be randomly allocated.
Okay.
So at the start, the patient may be on no active drug or one of the other three drugs. And if they're improving, they would just continue with that therapy.
Yeah.
If they're not improving, they would have they would be randomly allocated by a computer generation to a second drug.
So it could be.
And if they're still not improving at 12 weeks, they get everything. They get all active drugs.
And my next question, correct me if I understood wrong.
And so can I just interrupt there? So there's something called Bayesian statistics, which can tell you based on initial data about how well people are tracking. And so as part of this trial, we anticipate recruiting about 350 patients. And after, I think, 66 or 67, the plan is to sit down and look at how patients are tracking, whether there's a clear signal that one is working or one isn't, and in which case that therapy may drop off or have more patients allocated to that arm of the trial. So that is part of the statistics between in a adaptive platform design. And don't ask me about the statistics. There's specific groups of statisticians who know about that.
Will you also look at which second combination makes improvement?
Well, look, I think you make a really great point. There's probably not one therapy, but several therapies which might make a difference. And again, the value of this open label trial might be to say, look, STS does not work, right? And so it gets removed from standard of care. Or it might say sodium thiosulfate does work, but how about the combination of STS and vitamin K, right? And so an adaptive platform design will allow you to continue that trial within the platform and say you've got added value. And, we see that commonly. Like we say, look, we know that to help blood pressure, ACE inhibitors work. And in diabetes, the combination of ACE and SGLT2 inhibitors have added value, right? So absolutely, that's part of the design of the trial.
Janaka, you mentioned in 4 years from the NZASRDP, it's about over 330 cases reported.
Yes.
Is it big? In my observation for the last 20 years in New Zealand, I haven't seen that many calciphylaxis off late now compared to previous years. Is it because it's not been it was underreported? There was no registry to capture these, or are we doing our practice pattern has changed in terms of treating patient, which lead them to have more calciphylaxis now?
I think maybe if we look at the character, I think you've identified many of those key points. The first is that I'm not sure I recognized it till probably the late 2000s. I just thought patients have got bad vascular disease involving their legs. So it's potentially underreported, but also maybe the characteristics of the patients. So I think we're probably taking on more patients who have cardiovascular disease and with the raised BMI than we used to. So I think that might drive it. I've got to say, I'm extremely worried about the ability to manipulate calcium and dialysate. And, like there's this thing that we've moved to the smart bag system, but it's only got one calcium. We used to be able to use low calcium, and I don't think it's there. So I think that may also be a contributor. Yeah, but we used to be able to go
0.9, yeah.
We used to be able to go much lower. So my understanding is we've got 1.25 and 1.5, but we used to have like 0.9 and 1. So we don't have that much lower dialysate, which might remove, put the patient in a negative calcium balance for therapy.
Okay, thank you, Janak.
Hi, Janak.
Oh, sorry.
The funding for most of the medication like cinacalcet and everything. So we still having that special authority or they funded?
So cinacalcet is not part of the trial, but you're right. When cinacalcet came out 7 or 8 years ago, we had to write for an NPPA. Now we can actually get it as a special authority, and I 100% guarantee you I've hugely increased my prescription of cinacalcet, and I'm sure you guys have noticed that as well. Cinacalcet is not part of the trial design. Sorry, there was one more question here. No. Yeah.
Thanks, Janice. Is there a potential for home hemodialysis patients to be participants on the dialysis domain in terms of them doing longer dialysis? Like they can do 20 to 24 hours per week?
I strongly believe that increasing dose of dialysis is one of the appropriate therapies. And I'd also argue that a low calcium dialysate would be part of that. But we can absolutely randomize patients in beat calci to home hemo. If they go into the dialyzer domain, it would just be a change from to the medium cutoff dialyzer. I think participants going into the pharmacotherapy domain would not be possible, because you're giving sodium thiosulfate on dialysis. So the pragmatics of giving that at home is not really possible. Yeah. Sorry, one more question. I 100% agree with you. So, like if you look at Japanese data, not just the dose of, well, I think part of that's diet related, right? So if you look at the data of calcium phosphate parathyroid hormone in Japanese patients with ESKD, their phosphate control and their PTH is much better. Ours is terrible. And we prescribe a lot of phosphate binders when actually we need to be pushing diet and diet restriction much more. So I'm sure that calcium load is contributing. I think there is an argument about use of bisphosphonates and cinacalcet in that setting. But we don't, so many people will stop calcium and calcitriol and only reintroduce that if the calcium is going low. Some people have used use of bisphosphonates in this setting. But again, that's slightly controversial. The use of bisphosphonates in terms of bone and bone health is not really clear in patients on dialysis.
Thank you, Dr. Janak.
Thank you very much.
Really wonderful.
Thank you. Thank you so much. Nice to see you.
Great first session. Good to see a lot of interactions with the presenter. That's really good to see. Guys, we are breaking up for morning tea. So as we cross over a little bit of time, so please make sure we come back on time. Okay, maybe 10 minutes break instead of 15. Please enjoy your morning tea. Thank you.
Hello, everyone. Can't hear me? You know? Hi, everyone. We'll be soon starting our next session. So please, if you're done with your coffee or you can come, bring it along on your table. You're running a little behind, so would like everybody to come in. Hello, everyone. We're starting our session 2, and chair for our session 2 is Sujata Mani. Just a reminder, during the questions, when you have a question, raise your hand and please wait for the mic to come to you because we got people watching in Australia as well. That's all. I'll hand it over to Sujata Mani now. Thank you. Good morning, everybody. Please take your seats and get relaxed for the exciting part of the day. I'll just introduce myself. I'm Sujata Mani, clinical renal physiologist from TFA Tuora, Tokatumai. Today, for those of you who are here and had a chance to meet some of our new connections and able to meet our old colleagues while you are here, and also hello to everyone online. And I'm sure there will be so many amazing moments and also a day full of learning and new experiences. And it's my pleasure to kick off the second session of the New Zealand and Australia Society of Renal Dialysis Practice Annual Symposium 2023. We have Karen Prescott here, who has more than 30 years of experience in the pathology, laboratory, and in various medical sales roles in South Africa, United Kingdom, and New Zealand. She has worked in both the biochemistry and hematology departments, which has helped her understand the intricacies of renal dialysis. A passion for microbiology and improving the quality of our drinking water has resulted in her working for Swan Analytical New Zealand as a technical sales specialist. On behalf of everyone, it's an absolutely and huge pleasure to welcome Karen on the stage to give a talk on real-time inline chlorine monitoring, total chlorine monitoring. Welcome, Karen. Let's hear from Karen.
Good morning, everybody. Thank you for having me. I'm Caron from Swan, and my colleague over there is Keith Proctor from Swan as well. If you want to talk to us, we're just outside in the next to the tea area, the important area. So I'd like to just tell you a little bit about Swan Analytical for now, because most of you probably haven't heard of us. So Swan Analytical is a Swiss company, and their factory, that's the factory in Switzerland, in Hinwil, which is about an hour outside of Zurich. We've been in New Zealand for some time. Historically, though, we've been the experts in power plants in the power industry. Now, power plants actually use ultra-high purity steam to make their power. They choose Swan analyzers every time because the analyzers are robust, like everything that's Swiss made, right? So they're well designed, they're accurate, and very stable. In New Zealand, some examples of our customers include Contact Energy, Nova Energy, Genesis Energy. Then we have the dairy factories as well, because they also need ultra pure water for their processing. Fonterra, Mataura Valley Milk, and Open Country Dairy, some of our customers. So Swan recently entered into the water industry and now make various online water monitoring analyzers that test things like pH, turbidity, chlorine, ozone, fluoride, UVT, etc. We are continuously growing in New Zealand, and currently we're in the municipal, industrial, and now healthcare markets. So that's you guys. Healthcare is a new market for us, hence you haven't heard of us much yet, but in Australia we're quite well known already. So we have the AMI CODES TC analyzer. TC stands for total chlorine. What this does is it's a continuous monitoring analyzer for total chlorine, and therefore your chloramines that are very important in your dialysis water. It's very accurate, so it's non-objective compared to your dipsticks. It's automated, it tests every 10 minutes. It's quantitative, gives you an actual result, a number, and it records the data in a graph format, which I'll show you in a minute. It warns, so the main reason you would have this, it would warn of any total chlorine breakthrough after carbon 1. And you want that because as soon as you get a warning, you want to take the patients off dialysis. You don't want that chloramine getting through to your patients. The graphs that we have in the cloud can be shown on your mobile devices or your PC, and it can alarm you in real time. So where would we install the CODES TC? Well, it would be in your RO room where your water is purified and filtered, and we would put it in between carbon 1 and carbon 2. We want to measure the chlorine before it reaches the patient, and we need enough time between reading and taking the patients off dialysis. So therefore that we put it there after carbon 1 before it's even had chance to go to carbon 2. Why do you need this? Well, because it tests every 10 minutes, it obviously increases patient safety, right? There's less risk of hemolysis and resulting anemia due to chloramine breakthrough and chloramines in the dialysate. You don't want that. You have peace of mind. It gives your staff peace of mind, your patients peace of mind. Even during the dialysis process, it's measuring all the time, every 10 minutes. It gives your staff confidence that everything is okay. It gives accountability. It records the data, so everything is recorded if there's any comeback ever, heaven forbid. It increases the staff time with your patients. So instead of your staff having to go into the RO room, do the dipstick test, write the result down, spend that time washing hands, blah, 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 all of that, it increases the time with the patients, right? This is what the graphs look like. So this particular graph is from an actual hospital in Australia, a well-known hospital. And they decided to have a CODES analyzer after carbon 1 and carbon 2. The reason for this, I believe, is because their water is particularly bad and their chlorine levels go up and down quite a lot. And so they decided to do this. Now, if you have a good look, I'll show you. This red line here is the 0.1 ppm limit that we talk about. The blue is the real-time readings in graphic form. And then this vertical line here is the beginning of each shift. So you can see here on this day, everything was fine. Second day, everything fine. Third day, they had a breakthrough after carbon 1, and they would have got an alarm there. However, it didn't break through carbon 2, which is good. But they had a warning that something was going on, right? The next day, they had 2 huge blips in chlorine levels. And it even went through big time after carbon 2. So this, fortunately, they were alerted here and were able to realize something was wrong, take patients off dialysis, and not have any patients on dialysis this day here, where things could have gone horribly wrong. Now, just remember that currently, the way we test in New Zealand is at the beginning of each shift with a dipstick. It's incredibly objective. If they had tested there at the beginning of that shift, they wouldn't have detected anything. At the beginning of that shift, they wouldn't have detected anything either. That's when things were pretty normal. So that just gives you an idea and a really good example of how this can be really helpful. There's been many examples of articles written in medical journals around chloramine and resulting hemolysis, resulting anemia. Patients have died. In a particular case, around 30, I think it was 20 years ago in a prominent hospital in Sydney, there was a big outbreak. Patients ended up in ICU. And it was found to be due to the chloramine levels in the water. So we just really need to think about that. It's not something that's been looked at or focused on. There's always other things that seem to come up, but it is important to remember that this is an issue. So this is an interesting article that came out in 2004. An American hospital. They said there was an anemia outbreak identified in our HD unit. The dialysate chloramine levels had risen from less than 0.1 milligrams per mil in May to 0.27 milligrams per mil in August. Other parameters of the water quality were within accepted standards. Hematocrit and hemoglobin returned to basal values after 1 month without changing recombinant human erythropoietin doses and with exchange of activated charcoal column. Chloramines, that's chlorine and ammonia, are used routinely to disinfect and sterilize potable water. So this is what's added, obviously, at the water treatment plants. High blood levels of chloramines are associated with hemolysis and rarely methemoglobinemia. Uremic patients have a decreased ability to withstand oxidative stress. And this is the most important thing we need to remember. The renal patients have a decreased ability to withstand this oxidative stress that the chloramine puts on them. It is postulated that the antioxidant capacity is reduced, yet the mechanism remains unclear. Patients on maintenance hemodialysis are vulnerable to chloramine toxicity if chloramines are inadequately removed from the water. Over in Australia, we've currently got about 25 hospitals who have the Code STC installed in their RO rooms. And I'm very happy to say we have one in New Zealand now at Auckland Hospital. So those of you who are from Auckland Hospital will be quite aware of that. In their acute hemodialysis unit. And Jason Way gets the results on his mobile phone and he's alerted when the level goes above 0.1, which so far hasn't happened, which is awesome. How can you get this installed in your particular unit? Talk to us. We're just outside. We have customer support. So there's 3 of us in New Zealand. We travel the country. We have a service engineer, my friend Keith. We can change reagents for you. They last about a month, or you can do it yourself. We have annual services that we can do, and the telemetry can be arranged. And the telemetry being the fact that it talks to the cloud, the graphs are shown in your computer or your mobile device. Thank you. That's all from me. Any questions?
Hi. I have 3 questions actually. Basically, to start with the graph, what you showed, I need a clarification on the graph. You mentioned earlier it's per shift, and then you started to refer it as per day. Your graph, earlier graph. So.
I understand what you mean. So this was a hospital that had 1 shift a day.
1 shift a day.
Yeah.
So when you say that 1 shift a day, they started there on the 3rd one. Okay, they started, and then the 4th.
Yes.
How can that rapidly spike up both filters?
On day 4.
1, 2, 3, 4. Yes, 4.
Basically, the filters have a certain capacity to filter chloramines. And when that capacity is full at 100%, there's breakthrough of the chloramines.
Sorry, I agree. But carbon 1 is first taking the load, but the second one is taking lesser load. So how come at the same time, simultaneously, both can break down?
I'm not sure I'm understanding.
The carbon 1 and carbon 2 filters, right?
Yes.
So same time, simultaneously, both had the impact. It shoot up. That's practically shouldn't be happening unless there is manufacturing defect with carbon 2, which is at the second one.
Keith?
Probably a good conversation that you had with your water supplier, with your water plant or RO plant supplier. So this is the analytics we're showing you what chlorine levels are after carbon 1 and after carbon 2. That's an experience that we've had over in Australia, is that the analysis shows what the performance of the plant is, and then that gives you the opportunity to go to the plant supplier or the plant's service people to say, actually, the carbon filter is not doing what it should be doing.
Thank you.
Yeah, so I understand now what you're saying. So it has been proven, an actual case just last year, in fact, that the people who maintain the RO plant were proven to be wrong. They were saying that our analyzer was incorrect. but we did test with a portable device and it was correct. And their filters were not doing what they were supposed to be doing.
Now that suffice. My second question is that 10 minutes. What is the need for every 10 minutes? I don't get that.
The reason it's 10 minutes as opposed to continuous or 5 minutes is that the contact time in the carbon bed, if I'm right with my wording here, Keith, the contact bed time is 10 minutes in the carbon filters. And therefore, we want to alert you before that 10 minutes is up and it's gone through carbon 2.
Okay, so if 10 minutes, what is the costing effect on that? That's my third question. Is it going to cost the consumable usages when it is
The
just
consumable,
10 minutes?
I understand what you're saying. The consumables will cost the same. So the reagents, there will be no difference in reagent cost because it uses a colorimetric method of DPD to test, and the reagent goes off after a month. So it's stable for 1 month. So irrespective of whether you test every 5 minutes continuously or every half an hour, those reagents need to be changed monthly.
Thank you.
You're welcome. Any other questions?
Apart from having your mobile alert,
Yes.
do you have any alert in the machine? If it goes more than the parameter set, does it alarm? How do we know?
So,
The machine itself, do you have any analysis?
Keith?
Yeah, so at the moment, we're sending text messages to the charges, whoever uses that, if there are mechanisms to put in place for audible alarms or visual alarms.
So there are different options. We can customize it for you.
Thank you.
You also don't have to have the pervasive, the telemetry that's required if you don't want it. If you just want to see, if you just want an audible alarm, for example, you can choose that option. Yeah. You're welcome. Any other questions?
Thank you.
You're welcome. Thank you.
Thank you, Karen.
I'll give you
Yeah.
a certificate.
Yeah, shall I just present a small token of appreciation for a valuable time and presentation? Thank you, Karen. And imagine for your question, I think Jason, technical advisor, get the alerts from that inline chlorine total monitoring, and if that reaches the action level greater than 0.1. Thank you. Yeah, that's a good point. Yeah, we can consider. Thank you. The next presentation is we will move on to the next presenter. This is about Dr. Vijay Nalamati. He's an early career nephrologist at Oxbury Hospital and having done medical training in New Zealand, including the medical school. His special interest is in drug clearance on dialysis, as well as patient-focused therapeutic trials. He's currently living in Oxbury with his Napier, Brown, and big wife, and 2 capital dogs. Now, I would like to invite Dr. Vijay Nalamati to give his talk on vancomycin therapy and dialysability.
Thank you all for inviting me to talk to you guys about my study that we did in our unit. Before you guys get to ask me questions, can I ask around the room who is using Theranova or middle cutoff dialysis membranes in their unit? Who is us? So Hawke's Bay, anyone else? Counties? And since you guys started to use Theranova or middle cutoff, have you guys noticed that the vancomycin drugs concentrations are lower or higher or any different? Or using more drug dose of the same patients? No? Okay, so I have no conflicts of interest to disclose, and I don't have any shares in Theranova. So the reason why we did the study, because our unit decided to change to Theranova or middle cutoff membranes, and we had no local protocols or understanding of drug clearance on middle cutoff dialyzers at all. And we had no protocols in our unit completely. And we were using North Shore counties, Manukau's and Whangarei's protocols. And every time we noticed that our patients had subtherapeutic vancomycin trough concentrations at the start of their dialysis. And that created more work for us, because then the nurses or the physiologists will ring the consultant on call and say, the trough concentration X, Y, and Z, what is the dose? And every consultant had a different way of doing things. So we just didn't have ways of, or we didn't know what we were doing, basically. So we went and did this pharmacokinetic study where we looked at the clearance of vancomycin on middle cutoff membrane Theranova and compared it to high flux membrane Rivaclear. And at the same time, Hawke's Bay was slightly behind other units. We infused only 500 milligrams an hour of vancomycin, because this was this historical concern that people will get red man syndrome. But other units around the world and around the country infuse up to 1 gram an hour without any problem. So we were a bit behind. So we did this study to prove that it can be done safely. So a bit of background about vancomycin. It's a glycopeptide with a bactericidal action that acts by inhibiting the peptoglycan synthesis, so stop the cell wall from formation around the bacteria. It is highly absorbed by the gut, and heavily excreted into the feces. So that's why we have to give it intravenously. And people who have normal kidney function, they have about 50% binding to the protein in the system. And if you have normal kidney function, 80% of the drug is excreted unchanged by the kidneys with about a half-life of about 6 to 8 hours. However, if you have kidney failure and on dialysis, that half-life can go up to 150 to 250 hours. And the protein binding goes from about 50% down to 18%. So you have a lot of drug that is free out there and hanging in your body for a long time. That's why we can give it up to 3 times a week without worrying about daily dosing in some patients. So what is important about VANC? It depends on the bacteria minimum inhibitory concentration. That means if you can't get the trough concentration right every time, you are at risk of not getting rid of the infection and actually causing more resistance. And in New Zealand, we are trying to avoid vancomycin resistance because we don't have access to those expensive antibiotics that are available in states overseas. And we don't have a lot of VREs yet so far, but starting to appear in New Zealand. And it's quite commonly used. I think majority of the units now use cefazolin and vancomycin as first-line treatment for a lot of line sepsis or any sepsis on dialysis, including a lot of gram-positive bacteremia because it's easy to use, it's reliable. You don't have to rely on your patients to take vancomycin. You just give it to them on dialysis. And most of the infections in our dialysis patients are gram-positive bacteria related to their access, fistulas, and lines. So it's easy. And we don't have that. We have quite a bit of MRSA in our dialysis units in New Zealand. So again, if they have MRSA, then you can use vancomycin. The problem is current guidelines assume that every patient is on high flux and that about 20% of vancomycin is removed on dialysis within 3 hours. And that's why we went from, when we used low flux dialysis, we used 1 gram of vancomycin almost every session of dialysis. because there was hardly any vancomycin removed. And then we went to high flux and we created some protocols assuming that only 20% of vancomycin gets removed every 3 hours of dialysis. The problem is with vancomycin in our patients, we don't take into consideration those factors that patients have residual renal function. So if they pee about 2 liters a day, then they'll clear more vancomycin than other patients. We don't look into their effect about membrane characteristics or what are the dialysis prescriptions and the frequency of their dialysis. And we don't look into it, we take into account the permeability of the membrane. So we know, and like Janek said, middle cutoff dialysis are similar to HDF, but will do more clearance than high flux dialysis. Also, we don't take into account patient blood flow. So the higher the blood flow, you get more clearance. So some patients on the lines have much lower blood flows than those on fistulas. What makes things more complicated in hemodialysis is that vancomycin has a small volume of distribution and a low protein binding, and it has only about 1,500 its molecular weight is only 1,500 Daltons. That means it's easily cleared on dialysis. And like I said, about 4 hours of the hemodialysis, you get rid of about 20 to 40% on high flux. When middle cutoff membranes became a new thing in New Zealand about 3 or 4 years ago, and we started using it about 4 years ago in New Zealand, and it showed that's almost the standard of care around the world these days. And because uremic toxins are classified into small uremic toxins, anything less than 500 Daltons to middle molecules weighing about 500 Daltons to 60,000 kilodaltons, water soluble and protein bound substrate. And we think that middle cutoff dialysis have more clearance than other high flux dialysis. And middle cutoff dialysis have been shown to remove much more solutes and compounds, which I'll show in the next slides, compared to high flux, and similar or higher than even HDF in some of the patients, including beta-2 macroglobulins, as well as free light chains. And there is probably some survival benefit because more data is coming out from the world that people on HDF do better than high flux, and more units are switching to HDF. But now in Europe, Theranova or middle cutoff dialysis is the standard of care in a lot of countries. So this is slides from Theranova. If you go for the top here, you have high flux dialysis to HDF around here, and vancomycin is slightly higher than even creatinine clearance sits around here. And then all these molecules are removed by Theranova more than HDF and high flux. Okay. So this is the initial studies that came from 2017. It looked at the overall clearance of MCO dialysis versus high flux, and it shows that you get more clearance of these molecules that are uremic toxins here with Theranova 400 compared to high flux. But remember, if you look at these, all these patients had about 4 hours of dialysis and a QB of 300. So you need to have really good access to achieve that clearance. And these molecules in some meta-analysis and some studies have shown to cause heart disease and strokes and heart attacks in our other patients. And that's why our patients tend to die a bit quicker. So that if we remove these molecules from our dialysis machines, using dialysis, then people will technically have a better survival, but yeah, it's yet to be proven. Once again, if you look at the reduction ratio, you can see that Theranova had better clearance reduction in those molecules compared to high flux. When we look at the overall clearance compared to HDF, this time, again, the clearance was a bit better, except for alpha-1 macroglobulin, which is not significant, but overall the trend was consistent. However, the difference was the blood flow was about 400, which I don't think that many people out there have a blood flow of 400 these days, especially on HDF. Most of them tend to have cardiac disease and heart failure. So we decided to change to middle cutoff dialysis. There's no data about drug clearance. Multiple drugs we use, we just don't know what to do about them. And our primary aim was to determine the extent of vancomycin concentration reduction and pharmacokinetics using Theranova compared to Rivaclear or high flux dialysis. So what we did was a small study, and because of the ethics, we couldn't just give our patients willy-nilly vancomycin and do a pharmacokinetic study, because otherwise we're exposing them risks of harm and resistance. We had to actually wait for patients to get sick. And that was actually so kind of reflecting real life situation when you would use vancomycin. So we had to wait for these patients to actually get sick and consent to them. And it's most of these patients were males over the females and were on dialysis between 9 to 4 years. Some of them had a native fistula, some of them had grafts, some of them had tunnel line. So all the variety of abscesses. And what we did was, the day of the infection or the suspected infection, they would give them vancomycin as per the local protocol. We didn't interfere. But after that, we alternated the dialysis between every other session of dialysis. We would alternate between middle cutoff dialysis and Rivaclear to see whether it was any difference in removal of vancomycin. And we also decided to do the math and the pharmacokinetics that we will only give them vancomycin in the last 1 or 2 hours of dialysis, so we can do taking blood samples on dialysis. Okay, and I basically supervised the drug dosing for all these patients throughout the study and adjusted the dose based on their trough concentration. So most of these, actually the patients were Maori majority, and most of them had a BMI of greater than 30. And most of the sessions on dialysis had blood flow of less than 250, sorry. And what we saw that these patients had, so I'm going over time, had 65, most of the samples were taken at 0, 5, 15, 30, 45 minutes, and 120. So you can get an area under the curve. And the more samples you take, the more accurate are the results. However, I didn't have more of Shiri and Shadu to do blood samples for me on those patients. So we had to rely on these samples to take. And we took majority of these samples within the time frames given to us. So the pre-dialysis median concentration was 17.2. And on 6 occasions, the levels were above the cutoff of 15 to 20 for Theranova, and only samples were less than 15. So by doing this study, we were confident what we were doing. We were achieving good trough concentration without causing any adverse effects or any resistance. And the median percentage of vancomycin reduction at 120 was 39% using Theranova or medial cutoff membrane compared to 34%. And the range is quite wide, and I'll talk about it in a minute. Why is that the case? And the median pre-hemodialysis concentration of vancomycin actually declined from about 15.9 to 9.7 using Theranova compared to high Rivaclear. So there was about 15% difference or higher drop in vancomycin on Theranova. So these are the graphs that show the reduction rate or the decline in the vancomycin concentration. And you can see the separation that Theranova was higher than Rivaclear. Okay. So if we were to do this for more 100 patients and continue looking at the number of times, etc., and to draw it for the 5 hours of dialysis duration, we will find out that the half-life of vancomycin on high flux was 280, and on Theranova, it was 240. That means there was more drug being cleared on Theranova compared to high flux. All right. The problem we couldn't analyze, but we found that people with a higher BMI had more reduction in the rate, and people with higher blood flow velocity had better clearance in other patients. So this is the only study that we know around the world has been done looking at the drug clearance. It's the first of its type. It's been published online. It's available to you. And it showed that the reduction in vancomycin was 15% higher with Theranova compared to high flux, and with the reduction ratio about 34%. The problem with this study was it's quite small. We didn't take into account the patient's urine clearance, and the confidence intervals were very wide, so we couldn't say these were statistically significant results. However, they are reflecting real life situation, and we've had, as a result of the study, we have written a Theranova specific protocol for vancomycin. And so far in the last 2 years, 90% of the blood tests are within the trough concentration pre-dialysis without any significant recurrence of sepsis, unless it's related to the same tunnel line in our unit. So this is my, talk. Any questions? Oh, cool.
So much.
Thank you.
Mr. Navati, for an amazing presentation. As a token of appreciation for the time and valuable presentation. Thank you. And the next presenter is Aparna Nair. She has completed her degree at Monash University. Aparna joined Melbourne Health as a renal physiologist and has been working for Melbourne Health for the past 17 years. Aparna has worked as a satellite dialysis manager and as an educator on holiday cover roles and participates in training and precepting graduate students. Aparna joined New Zealand Australian Society of Renal Dialysis Practice as one of the board members in 2022 and is passionate about advancing our renal physiologist workforce through continued education and innovation. It's our pleasure to invite Aparna Nair on stage to give a talk on Royal Melbourne Hospital COVID Infusion Center experience. Thank you.
Thank you, Sujata. Good morning, everyone. Today, I'd like to talk about a remarkable response to the unprecedented challenges that the global COVID-19 pandemic presented to the healthcare sector. In particular, I'd like to highlight the incredible efforts of Melbourne Health in addressing the rising requirements of the dialysis patients affected by the pandemic. As the world grappled with the virus, Melbourne Health responded promptly by establishing a community COVID center at its Royal Park campus in the city. This center, known as the CIC, played a crucial role in providing specialized care to high-risk COVID-19 patients. The CIC, which stands for COVID Infusion Center, is a 10-chair unit located at the Royal Park campus. It opened its doors on February 7, 2022, with a clear aim to deliver COVID-19 treatments to high-risk patients. The center provided access to approved antiviral therapies for patients at the risk of developing severe symptoms or death due to the COVID-19 virus. Other clinical services such as pathology services and blood transfusions were also offered at the CIC. Patients admitted to the CIC were carefully screened to determine whether they require Paxlovid or remdesivir treatment following the Victorian government's COVID-19 positive pathway stratification criteria. The unit was equipped with 5 dialysis machines, portable reverse osmosis machines, and 2 medication storage rooms.
At CIC, we could comfortably accommodate 5 patients for hemodialysis treatment, with an additional 2 beds used for cancer patients receiving intravenous infusion of remdesivir. We utilized AK-98 Gambro machines with portable RO units for hemodialysis. Stringent disinfection protocols were in place, with dialysis machines disinfected using a citric acid disinfectant after every treatment and a sodium carbonate disinfectant applied weekly. Now, these are just a couple of pictures of the unit. Our practice recommendations state that when a COVID suspected dialysis patient presents as low risk, they can be managed in their local dialysis unit, provided appropriate facilities are available and ensuring appropriate precautions are implemented. If they present as a medium risk, consultation with the relevant renal team will be undertaken to determine the appropriate place for treatment. Confirmed positive cases on arrival to the dialysis unit were transferred to COVID infusion center using non-emergency ambulances or dedicated bus funded by the department or by the patient's family members. If a patient presents as a high risk and needing hospital admission, they will be treated as per the RMH protocol for patients requiring dialysis and admission. Melbourne Health has also developed a secondary COVID-19 clinical practice guideline aimed at guiding the clinical staff in the RMH Department of Nephrology to provide care for RMH and metropolitan satellite dialysis patients who are either suspected or confirmed positive for COVID-19. This comprehensive document covers identification of patients at risk, assessment and escalation of patients, clinical management, and the management flow path for COVID-19 positive hemodialysis patients. Identification of patients at risk. The points to be considered being identify confirmed and suspected COVID-19 cases before entry if possible, inform patients to contact a dialysis unit for advice before attending the treatment, especially those patients who have fever or new onset of respiratory symptoms, or those who have been in contact with a confirmed or suspected case of COVID-19 and have been told to isolate by the Ministry of Health, or those who have returned from overseas in the previous 14 days. All patients entering the health service must have a COVID-19 screen on arrival and on admission. The COVID-19 risk status to be documented in the EMR or EPIC, which is RMH Health application. Permitted visitors or carers must complete a COVID-19 risk assessment on arrival and allow medically stable patients the option to wait in their vehicle or outside the dialysis facility. Assessment and escalation of patients. All dialysis patients with new onset fever and or acute respiratory symptoms should be tested for COVID-19. If a new confirmed or suspected case of COVID-19 is identified in the dialysis center, as per guidelines, a hot zone is to be set up for PPE, including donning and doffing area. If a patient is unwell or has severe respiratory symptoms on arrival, as per nephrology team's advice, they may be sent to the RMH emergency. Stable positive cases were transferred to CIC, or alternative arrangements will be organized for their dialysis with the days and times. We also perform a COVID-19 PCR swab test in the dialysis unit before sending them to ED or CIC. Clinical management of suspected COVID cases includes dialysis in a separate room with the door closed with HEPA filters and McMondy hoods. If this is not available, allocate a well-ventilated space in a corner or end of row station away from the main flow of traffic, which has access to respiratory hygiene supplies. Management of COVID-19 hemodialysis patients flow path. This consists of the following points: confirmed patients that present to their usual dialysis units were transferred safely to CIC unit as per the protocol according to the schedule available, and unit managers will coordinate with the CIC unit management team. The swab test results are meticulously recorded in our EPIC or EMR data system, and a CIC team and renal team are promptly notified. At the CIC, a RAT or regular rapid antigen test was conducted on day 7 and 10 after the patient was transferred to the facility. Upon returning to the satellite units, no additional RAT is required, as RAT may be positive due to the viral shedding period being around 21 days. The McMondy hood or the personal ventilation hood is specifically designed to contain droplets and aerosols expired by an infectious or a potentially infectious patient. It is a transportable device that consists of a metal frame and a transparent plastic hood that sits over the patient. The McMondy hood has a powerful fan filter unit that draws the patient's expired air out of the hood through a H13 high-efficiency particulate arrestance filter, which scrubs the air of 99.97% of the particulate matter, including viruses. The device is large enough to accommodate a patient plus other medical equipment that may be attached to the patient. It is extensively used in our units to ensure a safe environment for both healthcare workers and patients. This picture shows the CIC snapboard where the patient information could be viewed while they were receiving treatment at CIC. EPIC or EMR is a primary application that verifies medical credentials before commencing any treatment for a patient. This health application tool helps the users to view appointments for multiple providers in one place. It uses the drag and drop features that allow staff to move appointments from the case report to the main schedule in real time, as well as perform scheduling functions for future appointments. So our COVID-19 infusion center provided space and specialist nursing care to patients who are COVID-19 positive, who require ongoing pathology, where attendance at a regular pathology service is not accessible, hemodialysis, life-saving drug therapies, blood transfusions, ongoing intravenous immunoglobulin, and medical procedures or dressings in consultation with the nursing staff. This is a dialysis patient summary page, which shows the dialysis navigator as well. As said previously, EPIC comprises information about identity verifications, demographics, diagnosis, admission and discharge, progress notes, infection status, referrals, medication, etc., to name a few. The unit was staffed by a combination of renal unit managers, renal physiologists, and nurses. The number of staff members varied depending on the number of patients using the facility each day. The unit ensured at least 2 staff members are available on each shift. That included renal physiologists from the satellite centers who have been upskilled to care for COVID positive patients. Patients admitted to CIC were carefully screened to determine whether they require Paxlovid antiviral or remdesivir treatment, following the Victorian government's COVID-19 positive pathway stratification criteria. Paxlovid is the first choice of treatment for mild to moderate COVID-19 in high-risk patients, but it comes with several drug interactions that can make it challenging for people with kidney and liver impairment or lactose intolerance. For those who did not meet the eligibility criteria for Paxlovid, due to these interactions, remdesivir treatment was provided intravenously in the COVID unit. Patients undergoing treatment at CIC were added to the patient database as a separate entity with their treatment and transfer information available on EMR as well as other nephrology databases. Outpatient registrars could be contacted via EPIC or EMR to dispense medications, and the remdesivir infusion could be ordered at CIC through EPIC. or EMR. After 1 year and 9 months of exceptional service, the CIC is being officially closed this month. So what's next for the COVID positive hemodialysis patients? Their care will be taken over by the newly opened John Perrott Kidney Service at the Elizabeth Street campus of Royal Melbourne Hospital. It is a 15-chair dialysis facility that was officially opened at the beginning of this month. COVID positive patients will receive their dialysis and intravenous infusions at this center. And pathology services for such patients will be offered by RMH Home Dialysis Service. In conclusion, as of mid-October 2023, the CIC had delivered approximately 535 treatments to around 142 dialysis patients. These patients have come from various facilities, including satellite dialysis unit, regional unit, home dialysis unit, acute dialysis unit, and various wards. The clinical renal physiologists from Essendon Fields and Coburg satellite dialysis centers have undergone specialized training to look after COVID-affected dialysis patients. The care will be transitioned to the newly opened John Perrott Kidney Service at the RMH Elizabeth as CIC officially closes this month. The dedication and commitment of the entire team that served at CIC have been instrumental in providing specialized care to those affected by COVID-19. And they continue to make a significant impact in the fight against this global pandemic. Thank you. You have any questions?
Hi, Berna.
Hello.
Just interested about the McMondy hood. Are you guys still using it, or is just was like one off with the COVID time pandemic thing?
It is still in the units and ready to be used because at times we have medium risk or low risk patients, those who have had contact with the COVID confirmed case, but the RAT shows negative and there may not be any symptoms. For such cases, if the CIC is busy or if other transport is not available for the time being for whatever reason, we still use it occasionally.
And is it kind of like a one-off use? Like, is it a disposable thing, or like how is it sterilized if you are reusing it?
There is a thorough disinfection process that to be followed at the end of treatment. However, the transparent plastic hood that sits over it, that's disposable. But the metal frame will be thoroughly disinfected after every treatment.
So was it like it was originally developed, the idea, the whole thing in Australia or somewhere else? It was
from my understanding, it was developed in Melbourne. Yeah, thank you, Chris.
Oh, yeah.
Yeah.
Thank you.
The McMonty hoods were a joint collaboration with one of the hospitals in Melbourne, Western Hospital and Melbourne University. So for the clinical side, the hospital did that part, and the biomedical side came from Melbourne University, and it was two people, I can't remember the names, Mick someone and Monty someone, but they came together and they developed this hood that was introduced pretty early in COVID, and we have had them throughout the hospital and within our units. The actual plastic hoods are quite expensive themselves, so we do reuse them for a single patient. So if we did have a patient that was consistently coming back, we would reuse their own hood for them, but they are disposable, and they've been a really good investment, but probably have cost quite a bit of money getting them because they are expensive as a single use item.
Thank you. Thank you, Kristen. Any more questions?
Hi, Padna. Apart from Melbourne, was there anywhere else tested, like Sydney or Western Australia or anywhere?
The hoods, yeah, in other place in, yeah. Okay, yeah. Apparently they are used in other places in Australia, I'm told, yeah.
Thank you.
Thank you, Rajiv. Any more questions? Right. Thank you. Thank you, Sujata.
Thank you very much, Aparna. There has been a lot of lessons we have learned, and you have been very kind to sort of condense and share them with us, and they are genuinely enough to help us in any other crisis. I hope fully that will not happen anytime soon. Thank you. Then we'll move on to the next presentation. The next presenter is Gayatri Devi. She's a clinical renal physiologist and clinical educator working at North Shore Dialysis Unit. Previously, she had a successful career as the National Clinical Manager in Freshness Medical Care in India and associated with Devita India Private Limited and Devita Asia Pacific as the head of clinical operations and lead clinical services specialist. She also worked in National Kidney Foundation Singapore and did short projects in Devita in Malaysia and Jeddah. It's absolutely my huge pleasure to invite Gayatri Devi on stage to give a talk on about patient feedback project on 2023.
Good afternoon, one and all. I would like to take this opportunity to share the recent patient feedback project conducted in our dialysis unit. My aim with this presentation is I'm going to cover the project background, to touch base on the survey conducted in our dialysis center by patient experience team, and our approach to address the dialysis survey outcome 2023 result to enhance our service to provide positive patient experience. Project background. Yeah, sorry about it. Project background. The most traditional feedback mechanisms such as surveys and complaint systems are struggling to elicit good response rates and be used to make a difference. Healthcare providers are receiving large amount of often unacknowledged commentary from patients and caregivers via feedback. Gathering, interpreting, and responding to solicited and unsolicited patient feedback is now established practice and fundamental to success. An effective patient feedback system will help identify the shortcomings of our healthcare services, which will help us improve our services and foster patient satisfaction and positive patient experience. To review systematically the published patient feedback gathered by the patient experience team from the participants for improvement of quality standard of care in North Shore Dialysis Center for providing positive patient experience. So what is patient experience? Patient experience considers a patient end-to-end journey through the continuum of care. Patient experience refers to all the interactions patient and their family has with the healthcare system. This includes things like scheduling appointments, receiving medical care, communicating with healthcare providers, navigating the system, and overall satisfaction with the care they receive. Patients and their loved ones can provide valuable input on what a practice is doing effectively and where improvements can be made throughout their patient journey. The patient experience team evaluates how well patients are being cared for based on different aspects of their experience. This includes respecting their preferences, needs, and values. They aim to restore a human touch to healthcare by explaining things clearly, listening with compassion, showing empathy and concern, and acknowledging patients' issues. This helps build trust with patients and assures them that we always have their best interest in mind. Patient reported experience measures. PREMS includes the satisfaction with care. The patient experience team conducted interviews with our patients undergoing dialysis. The team noticed that the patients were very impressed with the team, that we are here to hear their voice. The patient experience team shared us the comprehensive report encompassing the data of demographics as well as unaltered comments provided by the patients. We have not changed one single word. A key theme that is coming through from these interviews, especially with the men, is that many men have very little to say or they are of few words. This comes across our interviews. Women will speak up more and say it how it is. They all had a bit more to say than the men. Many men in general do not like to complain and they tend to minimize things. For some of you who are not aware of North Shore Dialysis Center, the Tarihoranga North, it is located in Shakespeare Road, Takapuna. We have 26 hemodialysis machines. We operate Monday, Wednesday, and Friday, 7 a.m. to 11:30 p.m., Tuesday, Thursday, and Saturday, 7 a.m. to 7:30 p.m. On-call duty is covered by after shift patients. So if you look at the demographics of the North Shore Dialysis Center, during the study period, we had 90 patients, 42 female patients and 48 male patients. And the patients by ethnicity, Pacific Highland are 31%, European 23%, Maori 19%, Asian 24%, and others were 3%. And patients by modality, interim 11%, and dependent patients are 89%. The patient experience team conducted the interview for 14 male patients and female 7 patients. The ethnicities to this group is we have a larger population with Maori 38%, New Zealand European 23%, Samoan 4.8%, Chinese 19%, and Fijian 14%. And the age distribution for this group is 40 to 50 years, 28%, 50 to 60 years, 14.3%, 60 to 70 years, 33.3%, 70 to 80 years is 23%. Time on dialysis, more than 10 years, it is 14%, 5 to 10 years, 19%, 1 to 5 years, 38.1%, and less than 1 year is 28%. Well, once we received the patient experience survey, we looked at the project, what is the problem statement and the aim statement. We created a project charter which had a background, how does this affect our patient care, scope, problem, and we developed a SMART aim, which is specific, measurable, achievable, and relevant and time-bound. We identified the project champion, our CNM was our project leader, and with the support of NST team, we were able to resolve some of the key issues. The problem statement in the survey was a patient feedback collected over time. The dialysis survey outcome 2023 to understand the potential barriers of patient experience by the North Shore Dialysis Center staff, services, and organization capacity to combine, interpret, and act on patient experience data. Our aim is to improve the North Shore Dialysis Center patient satisfaction by 15 to 20% in the next 3 months and employ the right strategies to develop our process and train our staff to enhance the services and provide positive patient experience. Now I would like to share some of the satisfaction expressed by our happy patients, where patient experience is best. Patient feels safe, supported, and grateful to the team efforts. Several patients specifically mentioned staff members whom they connected with exceptionally well, and their names have been included in the report. Notably, one individual's name was consistently mentioned by multiple patients. Some of the exact comments by the patients were, I'm very happy with the staff. If it wasn't for dialysis, I won't be alive, and it is a free services as well. All the nurses here are nice ones left, and the new ones are nice too. Happy with the nurses and doctors here, have been well looked after. Everyone is good here, can't think of any improvement. The social worker here is very helpful. I've seen the dietitian lately and I feel much better after speaking with her. I have made changes in my diet and feel less sick. Overall, patients feel like a part of supportive family community and have had positive experiences with the staff and services provided. Now I would like to touch base on the concerns expressed by our patients, the cause and effect which we looked into, and some of the highlights are from the patients, caregivers, and the doctors, where they have to wait for a long time for the taxi, selection of bed and chair, and some of the patients express that there is a language barrier where, for example, like a Chinese patient, when we are not able to communicate with them, and access for the specialist doctor. Overall, the patients have shared concerns about safety measures, waiting time, communication with staff, provision of care, language barriers, unit conditions, access to specialists. This feedback comments highlight areas that could be improved to enhance to overall experience and satisfaction of patients receiving the dialysis treatment. So why is understanding patient experience important? Because it provides voice for patients, enables patient engagement with home healthcare, increases patient safety, improves quality of health. We know that patient experience is a good indicator of the quality of our health services. Better experiences, stronger partnership with consumers, patients, and family-centered care have been linked to improved health, clinical service, and care outcomes. Patient feedback is used by our teams to monitor and improve the care we provide. Understanding how people experience healthcare gives us a valuable insight and an opportunity to celebrate on success, what we are doing well, and what are the areas we can do better. We looked at the process, our approach to follow the process, a series of actions done repeatedly together to transform inputs into outcomes. To review systematically the published North Shore Dialysis Center report relatively for interventions informed by patient feedback for improvement to quality of care in hospital settings. This process helped us to close the gaps under our scope in a timely manner successfully by creating a platform for change, leveraging transparent escalation and effective training to resolve. So what are the results we learned? We had a direct insight on what we are working well, and specific patients' feedback helped us to make the patient experience personalized. Further improvement in the way positive experience is delivered and achieved. So we categorized the categories into high, moderate, and low. The areas which we are able to improve immediately for the better quality of care was our quick wins. For example, patient waiting in the waiting area for a longer time, or language barriers. And there was a complaint that the staff speaks in their local language. So all those things, we educated our staffs to follow the Vitamata policy for not to speak in the local language. And for the I will talk in the next slide that what we did the next step. We charted everything for the area of improvement, plan of action, timeline, and who's responsible for what, and whether the issues is open or closed. So, for example, one of the patients said that staff are feeling very shy to communicate with the patients when the TV volume is high. So it's a responsibility of the staff when the patient is there for orientation to inform. So something like this, the small things which we educated our patients and the staffs to follow. And for example, in this, if you see that the unit condition is hot, which is not under the clinical scope, which we have to escalate to the operations. Then comes our approach. We literally had a lot of useful information. We focused on what is our best approach to take on board this belt of valuable feedback we have been given by our patients through the patient feedback team. As we move forward into the Center of Excellence paradigm, one of the key domains is the quadrant for positive patient experience, what we have accomplished through their visit. Adherence to Vitamata values, how we aim to be with the people we serve and with each other, and set our ambition to provide the best care for everyone, to make everyone feel positively welcomed and valued. We also had a transparent communications with the support of psychologists and social worker, emotional support to improve the comfort and coping for patients were followed. We had patient education champions identified and also the patient advocate. We analyzed the feedback and determined the impact, recognized accomplishments, and improved over time. So how can a patient experience program benefit staff practice? This helps us to improve patient engagement, enhance physician-patient relationship, improve patient outcomes, help identify areas for improvement, help recognize and celebrate what we do well, and improve patient satisfaction scores. I've just taken one area, like for example, when the patient has raised in concern for waiting time and taxi time, we looked at the center patients by residence. So 48% of our patients are there in north, and from west we have like 50%, and out of area 2%. So again, if your patient X is 5 hours dialysis and patient Y is 4 hours dialysis, they have to wait for 1 hour for the taxi. So we educated our staffs to start the patients who are for the long hours, and then to start the patients who are having a shorter duration, which could have been helped. But maybe in future, we might have to plan for the center in the west. Another example is doctor follow-up. Again, due to the time crunch, and what we did is we discussed with the medical director with the help of the registers, or based on the case basis. The register used to connect with the patients, and in case if they need, they would have been referred to the specialist. So again, we categorized who is responsible for what, and whether the issue is open, resolved, or yes or no. And the next one example is, again, as I mentioned earlier, which is not in our scope, but again, when the patients complain that unit is hot, we escalated this issue to the concerned stakeholders. Operations to take up the genuine request from the patient. Patient staff safety lies with the link representative. Support with the short-term measurements, and the capex was approved for the heat pump replacement. The purchase order has been done. Again, it is all time consuming. It takes time for us to receive. We are awaiting to receive the new heat pump, which will be installed and commissioned soon. So as a next step, we have to bridge the gaps. Primary model of care is implemented. Structured patient education is implemented. Patient advocacy, we identified a patient, but again, the talks are going on how to proceed with that. And based on the repeated feedback, we see that whether we have improved or whether we are on the same areas. We also, this is a screenshot of our first newsletter, which has been shared with the patients for them to know that what we are doing. The areas are highlighted here, like for waiting time for the taxi, communications and all. And as a next step, once it is resolved, so the patient feels that their voice is heard, and they will have a better positive patient experience. I think I'll stop here in the interest of time. Any questions? Any questions? Yeah.
All right. Thank you very much, Gayatri, for your presentation. I think we have learned a lot from the lessons from the previous feedback project report from Gayatri from Vitamata, and we can take this lesson about this, and then we can have positive patient experience by identifying the gaps where we can improve on patient's experience. Thank you. And the next presenter is Ruchi Pant. She was born in Nepal, and as soon as she finished her bachelor's degree in dialysis technology at Narayana Hrudayana Institute of Medical Science, Bangalore, she moved back to Nepal for 5 years to build a career before moving to New Zealand. Since March 2021, she's been working as a renal physiologist at Team Mataha Mai Ox Bay. And in addition to working as an health and safety champion for the renal service, Ruchi has got a lot of qualitative initiatives on the go. As a hobby, she enjoys hiking and swimming. Okay, I would like to invite Ruchi on the stage to have a presentation about Cyclone Gabrielle and their experience and learning. Thank you.
Afternoon, everyone. I'm a little nervous, so bear with me while I go through this. All right, Cyclone. Before I start the presentation, a quick disclaimer. This is an original presentation of Saija Thaikande, who was a renal manager at Hastings Hospital. I thought it was an experience worth sharing, so hence I'm here. All right. So the main objectives of doing this presentation is to understand what happened, how all of this unfolded, and to discuss where we prepared for what was coming our way, and the challenges we faced, the steps we took to overcome it, and to reflect on what we did well and what can be done better. And we'll also discuss about what we need to do it in the what we need to do for if it happens again in the future. Now, on the 8th of February earlier this year, Met Services New Zealand issued a warning of tropical cyclone and heavy rainfall in Auckland, Coromandel, and Northland region. So if you see in the map, Hawke's Bay is in the orange zone. So it's fair to say that we weren't quite prepared for what was coming our way. And on the 14th of February, Valentine's Day, is when Cyclone Gabriel hit Hawke's Bay. Now, before I talk about the impacts, it's necessary to understand how we are located. So Hawke's Bay Hospital provides renal service to patients from Wairoa and Napier, Hastings, and Central Hawke's Bay. So after Cyclone Gabriel, as you can see here, the State Highway 2 that connects Wairoa to Napier was completely out. There were multiple slips and slides on the road, and bridges were collapsed. Similarly, 3 roads that connect Napier to Hastings were either severely damaged or out. And the State Highway 2 that connects Hastings to Central Hawke's Bay was also out. So we had roads that were washed out, bridges that collapsed, and railway lines were out. Now, this all led to a whole lot of problems. Firstly, power failure. So it not just affected our daily lives, but also affected the treatment of patients, especially those who were doing peritoneal dialysis at home and home hemodialysis. We had communication network failure and patchy network. Like I said earlier, we had collapsed roads and problems with rail network, multiple slips and slides on the road, and state highway was closed. And all of this led to displacement of our patients. So we're constantly trying to locate where our staffs were, where the patients were, because they've been moved to evacuation centers. And also, all of this also led to supply chain issues due to the road closures. So our initial response was to have a team debrief on the morning of the 14th of February. So we quickly got into collecting a list of staffs who were stranded in Napier, and also our staffs from different designated areas, that is peritoneal dialysis, home hemodialysis, and in-center. They started trying to contact their patients. Patient-wise, again, we collated a list of patients who were from isolated areas, and we triage dialysis patient for treatment. So we have a big group of patients who come from Napier to Hastings for treatment because the roads were closed and only few emergency vehicles and ambulances were allowed to pass. So we had to triage patients for treatments, and treatment plan was established. We worked in partnership with the Coordinated Incident Management System and Emergency Operations Center. We also collaborated with taxis, and renal outpatient clinics were cancelled and done virtually where possible. So our initial challenges was because there was network outage, we weren't able to reach the patients. So our staffs, they were driving home to do face-to-face welfare checks on patients and their family. And again, there were places that were out of reach due to mass floods. We had patients who had been displaced and they were in evacuation centers, and road transport was out, 3 major highways were closed. So what did we do well? We worked as a team. It was a great team response. We had all hands on deck, trying to contact the patients, trying to locate where they were. And there were times when patients came for dialysis, and then we got the news the road has been closed. So we're trying to find places to put them after dialysis, like social admissions, or trying to find the spots for them in the evacuation centers. And we worked in partnership with MDT. No patients were harmed and no one missed their treatment. And we kickstarted RMO and RN-led team renal hub at Napier City Medical. So what we're doing is for peritoneal dialysis patients, because there was no power at their homes, we had organized a space for them to come to Napier City Medical and do their dialysis there.
We also did welfare checks on patients, whānau, and staff. We had worked in partnership with the Central Hawke's Bay and Wairoa hospitals, and all patients were accounted within 5 days. So the last patient we accounted for was a gentleman from Wairoa. We weren't being able to contact him for 5 days, and on day 5, he was flown from Wairoa in a helicopter to Hastings Hospital. And lucky for us, he's a really good man with good dietary restriction and food restriction, so he was all well. We have prompt communication. We also worked in partnership with EOC and Civil Defense, and we're quickly able to mobilize supplies and logistics to isolated localities. And we created space in the in-center dialysis for the home hemodialysis patients and developed in cyclone impact data. We also made sure there was stable supply chain for home patients, and we did staff and patient welfare plans. Now, what we could have done better is we could have had more collaboration with the EOC and CIMS team. And because renal is such an specific area, we have patients who are very vulnerable and have very different needs. We should have invested a bit more time to understand the need and challenges for specialty services like ours. And during times like these disaster, there are multiple channels of communication. So we could have had a better communication channel. And we being the experts, it would have been better if the subject matter experts were making the decisions during these incidences. And also, if we could have early identified the evacuation centers and equipped them properly. So these are the learnings from the disaster. We learned that we need a renal specific emergency disaster management plan. So we're currently working on a plan at the moment. We did have plans for fire and earthquakes, but we didn't have one for cyclones, so we're developing one. And we also learned the need of locality hubs to deliver care, especially places like Wairoa, which could have been completely cut off when something like this happens. And we learned that it is necessary to partner with other entities like EV, NGO in localities. And we learned what a great team we were and what we could overcome with the team strength and to appreciate the local knowledge. So what we need to do in the future, we are, as I said earlier, we're working on a comprehensive disaster management plan. And we need to have a better communication system. And we need to have renal clinics in localities that are isolated, which is Wairoa again and Central Hawke's Bay. And we need extensive collaboration. And for situations like this, no matter how many books we read, it will not prepare for something like this. So we need to think outside the box when it happens. Oh, I think I finished before time. So any questions? I might have a video if it does play. I'll see if it does.
Hi.
Sorry. Yeah.
Was there anything referred back to the earthquake disaster that took place from the Christchurch, the similar scenario? Was it helpful anytime? I think
yes, Sarju being the manager, you'll be able to answer that properly.
Sorry, what's the question, Papa?
Anything that from the Christchurch incident, was it helpful to refer back and do with your scenario?
Unfortunately, Christchurch never had any disaster plan. And
what they had, similar kind of things, right?
It was worried about the biggest infrastructure damage for Christchurch was water treatment. And they're still working on a disaster management plan. So Tifatorais, and especially with the new renal network, we will be working on a national disaster plan specifically for renal. And the question is whether it's helped anything from Christchurch experience.
To get back or a lead from that to say that, okay, that can be utilized or implemented or further formulated from that?
My answer is no.
And I got another second. Have you thought about the communication process, anything to do, like Vaidua, right? That's completely cut off from the main city. So for comms, anything?
Yeah, because of the power outage, what happened is a lot of the.
No, I'm asking as a futuristic.
Yeah. This is from the learning. What we understood was the power outage created all the Vodafone, Spark, every signal towers cut off. Then the civil defense took over and they installed few generators to run these towers. Then people started stealing those generators. So end of the day, there was literally no power. So how can you establish a new network system without power? That is the biggest question. And how would you communicate?
Can I suggest?
Yeah, go for it.
Sat phones.
Yeah,
sat phones are one of the best one to incorporate or get connected with under these circumstances.
Yeah, so we work
with the board install that in with the government and get it done for the places to prevent that.
So there's a satellite company owned by Elon Musk. So we didn't get in touch with him, but we got in touch with his company, and we managed to set up satellite hubs, satellite phones for our rural areas. That's how we managed to get hold of the fifth patient on the the last patient on the fifth day. So that is still in work in progress. And also we kind of signed up a temporary agreement to install satellite phones in our localities like Vairova, CHP, and Napier. However, it's not renal specific.
Exactly.
Right? Yeah, it's not renal specific.
Yeah.
So getting something, a satellite setup for a renal specific, having a budget of $7 to $9 million a year, probably not good enough to do it.
Is it for the whole country or just?
No, I'm talking about myself. Just
country.
That's what I said. There's a new renal network in the Tifatu setup. That is one of the priorities, improving communication, and also the patient information system, PIMS, which is it my timing? Yeah, we need a unified patient information system as well. So work in progress. The learning was really good. And surprisingly, one of the big challenges I faced as a manager was privacy, patient privacy, because all the other networks were failed, like cell phone, all those. We were communicating through Facebook Messenger. I know some of you might be laughing at it, but that was working. So in that moment, you need to think outside the box, whether privacy is a big thing or patient safety. Which one you put, prioritize?
It's communication. That's it.
Thank you. How was your PD patient, those who are on APD and post-transplant patients, because they need to take the blood test to adjust the immunosuppressant, how those patients were managed?
Yeah, for PD patients, what we did is locality-wise, we created some hubs with the generator power on. So we channeled everybody into one medical center rather than providing different generators to different individual people. So PD we manage that way, and PD staff we organize them to from Napier we have some staff based in Napier, so we let them do welfare check, blood testing, all those things for PD patients in the locality wise. Vairova, it was a challenge because we had no staff in Vairova, so the airlifting happens every 1 hour, 2 hours, so we send staff across to arrange those blood tests. And for transplant patients, we did a door-to-door, actually went to the individual patient's home. And fortunately, most of our transplant patients crew were based in Hastings and also Havelock North, CHP. Some of the areas were not affected by the cyclone. But again, I'm not saying that this will be the same case next time. So we need to create a comprehensive plan.
Agree.
Any other questions? You got a question? No?
Thank you.
Thank you. Thanks, Ruchi.
Thank you, Shaiju and Ruchi, for sharing your experiences, both positive and negative, with us. And it encourages us all to learn from experience. When things go well, we celebrate them. And when they don't, they are treated as an opportunities to improve. Thank you for all of you for your participation. I think lunch is arranged at the lobby. Let's have our lunch and please be back at 1:30 p.m. for the third session. Thank you.
Before we depart to lunch, can I please request, because we have a trade booth there with online clothing monitoring. So please spend some time and, ask your questions or get their brochures and stuff. And also, when we come for the vascular workshop, you might have already got a number for 1 and 2. Please don't mix, because my friend is in group 2, I'm going there. Please don't do it. So just stick with the numbers. And we will see you after lunch at 1:30. Thank you. Okay, thank you.
I think a little bit differently.
Hello, everyone. Can you hear me? Can you hear me? Hi, everyone. We'll be moving to our session 3. Please do come in if you're finished with your lunch. Thank you.
I think you did already. Yeah, very good at ringing now. True. Fair enough.
Attention, please be seated. We'll be starting our session 3 soon. Thank you. Very good afternoon to all. I'll be introducing our next session chair, Aparna Nair. Thank you, Aparna. You'll take the stage.
Good afternoon, everyone. Welcome to the afternoon session of the annual NZASRDP Symposium. I'm Aparna Nair, and I'll be chairing this session. Apologies that there have been a slight change in the program list. We've got Kristen and Rajiv presenting instead of Tina soon. The session will run from 1:30 till 2:30. There'll be 3 presenters. Let me introduce the first presenter to you, Rajiv Kumar. He'll be presenting percutaneous AV fistula. Rajiv Kumar is a renal physiologist at Auckland City Hospital. He graduated from India's most prestigious St. John's Medical College in Bangalore and completed his postgrad from University of Auckland. Rajiv believes that understanding the work ethically and culturally is the key in creating productive, efficient, and ultimately inspired workforce. Rajiv's hard work and dedication has been acknowledged by T. Toka Tumai, and he received Education Excellence Award from RSA in 2022. He has a special interest in vascular access and is a champion in AVF cannulation. Apart from his core responsibility at work, Rajiv is a cricket lover and plays regular badminton. Welcome, Rajiv.
Good everybody. This is post-lunch session. Hope it's, everybody's alert. I'm gonna introduce to a new topic, which some of you might have heard, some of you might be using it now, and some of you might not have even, experienced it. So it's recently developed percutaneous AV fistula had come to New Zealand just early 2023. Before it was quite famous in USA, other European country, but had not touched the market in Australia and New Zealand. So we are fortunate to have one of our center, Auckland Hospital, who is currently, doing the surgeries of this percutaneous fistula. So when we talk about percutaneous fistula, we have more than one. I will be mainly focusing on ellipsis percutaneous AV fistula, whereas the other wave limb Q and Gray's AV also a technique to have percutaneous surgery, but those we are not trialing in New Zealand at the moment. So ellipsis fistula, a minimal invasive non-surgical procedure performed to create a percutaneous AV fistula using the ellipsis vascular access system. Now, we talk about ellipsis fistula. It is less invasive and long-lasting. How it is? Ellipsis system is a unique single catheter, non-surgical option for physician to create a AV fistula, a traditionally invasive procedure that, until the advent of percutaneous AV fistula, had no change in more than 50 years. So we haven't had anything going into this field. We always have this, traditional AV fistula. We always create a brachial, radial, whatever. So now we got a new technique is coming to us. Provide a immediate suture-free, permanently fused anastomosis. So how it works? So the ellipsis system enables a reproducible, minimally invasive procedure that requires no implant, no suture, and allows patient to live with just a single needle stick. How and where is created? So it is created below elbow, perforating vein, which is 2 or more than 2 mm in diameter, proximal radial artery, which is again more than 2 mm in diameter, perforating vein, which is not less than 1.5 mm distance to the proximal radial artery. Basin outflow vein, again cephalic or basilic vein, it should be either 2 mm or more than 2 mm. So what they say, there are some limitations why we can't do below 2 mm in diameter. Now, this is the arteriovenous fistula ellipsis catheter. Now, it also has ellipsis catheter, so which you can see the down it is there. We have ellipsis crossing needle. So the needle which is there, this side, which is written ellipsis, and also have ellipsis power controller. Later we'll know what is the function, how it functions, the power controller, and how it fused the artery and vein. Ellipsis power controller is a reusable, non-sterile, portable electronic console. So you don't have to use and throw. It just use the device only to fuse the vein and artery, but you can reuse it again. So I'm just gonna play a small video just to make it understand how it works. Can just play. You can see the arterial vein is very close. Inserting the needle and then followed by the guide wires. Now this is where they fuse arterial vein. First the clamp, edge of the artery, and that's how the fusion takes place. After that, they put balloon to dilate the vessels. And you have artery and vein and how the blood has been circulated. That's it. We got AV fistula now. So what is the clinical evidence? What it suggests to us? The ellipsis system is the only one of its kind with 5 years US clinical trial, whereas on surgical fistula, which is invented years ago, we don't have any trials going on at the moment. So this was conducted in USA for 5 years. And the findings were 88% maturation rate was achieved in 90 days. So it was like 3 months. We'll come back later about having, why surgical fistula is slightly different than the percutaneous, why it needs longer days for the maturation. And also had 91.8% functional patency at 5 years, 82% cumulative patency at 5 years. And this I have taken from the Medtronic directly. Sorry, I think T is missing from Medtronics. Equivalent real world result. Now, these clinical trials, maturation and patency rates have also been demonstrated in registry trial data from more than 500 real world patients. And as I mentioned before, it started from USA and went to Europe. It didn't come to Asian side. So France, Germany, and the United States, and recently New Zealand has been we call trialing and have successful outcome. So we have almost more than 10 patients right now who's undergone ellipsis AV system, and 7 of them we are using it mostly in Auckland City Hospital and the satellite units. The ellipsis system is contraindicated again for use in patients. So some of the patient who has again less than 2 mm in diameter, we cannot have ellipsis system. And the simple reason is the vein is too small to have the guide wire and do the anastomosis and balloon up. Probably it won't be matured enough. So that's why for these kind of patients, the surgical creation is advisable. The ellipsis system is contraindicated for use in patients who have a distance between the targeted artery and vein more than 1.5 mm. So what I was suggesting, and we were talking about, it is done below the elbow, where is the medial cubital. We have artery and vein, which is very close, and that's the area they choose to have the system. So if the vein and artery is a little bit distance and more than 1.5 mm, they can't fuse. It's too long distance to fuse. So that's why these patients will be contraindicated and may not be suitable for ellipsis fistula. Now, potential adverse effect. So now, apart from patient who is going surgical AV fistula, most of the complications remain still same because you are fusing artery and vein. There is sometimes failure. Sometimes there will be aneurysm. Sometimes there will be failure. It might not develop. But you have Still syndrome, hematoma, infection, and again for ellipsis fistula, because it is not done surgically, we have to go for fistuloplasty later on after 2 months or 10 weeks, just to make sure that we got adequate dilation of the vein for cannulation purposes. Now, this is how the surgical AVF and percutaneous AVF looks like. You have on the left side surgical AVF. You can clearly see there is an anastomosis fistula where there's a clear artery, vein, and there's blood mix-up and how vein has been matured enough for the cannulation. The other side, you have a percutaneous fistula. You can see the small red dot where is perforated vein I have indicated. That's the place they do the surgery where the vein and artery has been fused, and all the rest of the anatomy looks same. The only advantage for this percutaneous fistula we have that we don't have just one vein for cannulation. As you can see in the surgical anastomosis, we got just one vein and you can cannulate. Where in percutaneous fistula, you have more than one vein to continue dialysis for long run. Okay, there are some difference in surgical and percutaneous fistula. So again, you have to undergo the surgery, which requires anesthesia. Whereas in percutaneous, you don't need anesthesia. You might get away with local anesthesia. Surgical, you need to have a high flow fistula, whereas percutaneous, you will have low flow. Surgical, because it have a surgery and a lot of procedure involved, might have more interventions, whereas in percutaneous, less interventions. The chances of having aneurysm is more in surgical fistula, whereas less in the percutaneous fistula. Wound infection, because it's a surgery, we might have an infection, whereas in percutaneous, there is minimal chance of having infection. Now, the surgical fistula, you have a selected place, you do radial, brachial, you can go thigh, whereas in percutaneous, we only have radial artery and below and vocariation. So that's one of the disadvantages. Another is surgical AV fistula. When you talk about it, takes longer time, maybe more than an hour. You have to, a patient has to undergo anesthesia and all, whereas this percutaneous needs only 14 minutes. And we also have said it's need a long learning curve, because once you involve a lot of medication, surgery, hospitalization, you need to talk and teach more about education, whereas in percutaneous, you might have to just leave it all those things. Okay, improved maturation time to dialysis. So monitor and complete maturation assessment of dialysis readiness. Again, you do the same thing what we do for the surgical fistula. You have the time for maturation. You have ultrasound after 6 weeks. Make sure it's dilated properly for cannulation. Same thing we follow for percutaneous fistula. The only difference, it takes little longer time. So you need a minimum 90 days, 8 to 10 weeks. The remaining things like palpable, visible access being required for many dialysis to perform maturation if needed to meet cannulation criteria. And what we do for intervention, we have a balloon dilation, deep vein embolization, coils, covital vein bending. These are the interventions we do if we have a percutaneous fistula. Now, now, once is you identify of the identification of the AVF outflow path cannulations. Once we know the fistula has been 8 or 10 weeks old, have been matured, we either take help from the intervention radiologist or the ultrasound guided. We will have later workshop about this, and we can draw a line just where we are going to needle and how big is the segment. As you can see clearly, there are more than one vein, the basilic vein, a perforated epicycle at this side, so you can have more than one vein for cannulation. I'll just play a small video for a minute. This is only talking about if you have a percutaneous fistula when you are cannulating, how it is different than the surgical AVF. Can you please play?
Ellipsis AV fistulas do not require an incision, and therefore it is unlikely that a scar will be visible. While assessing the fistula, you can feel the thrill and hear the bruit just below the antecubital region, where it is the strongest, and at the distal upper arm along the basilic and cephalic outflow. Both may be less evident than that of some surgical fistulas. This does not mean that the fistula is not functioning. While cannulating ellipsis fistulas, use a tourniquet to help engorge the fistula and improve cannulation success. With the ellipsis fistula, there is the potential for single or two vessel cannulation options. The patient's access physician should advise on the best location to successfully cannulate the fistula. For cannulation, note that you should use a shallow angle of entry, as percutaneous fistulas are not deeper than the normal surgical fistula, though individual anatomy can vary. Some new AV fistulas may benefit from shorter cannulation needles. Ask your patient's nephrologist if this would be beneficial. Just like for surgical fistulas, follow your institution's best practice policy for cannulating new AV fistula.
All right, thank you. And later this afternoon, we'll have a workshop where we talk about the cannulation of this kind of fistula. So thank you.
Thank you, Rajiv, for that wonderful presentation. Our next presenter is Kristen Schuck. She'll talk about professional development, job application skills. Kristen has worked as a renal physiologist for nearly 20 years and has been a clinical educator since 2010. She sits on the NZASRDP board and RSA Victoria branch. Kristen has a special interest in workforce development and has worked in a project role, as well as completing research and being published for her work in this area. Please welcome Kristen.
Thanks, Aparna. So I was standing at Melbourne Airport on Thursday and received a phone call asking me to put together a presentation for today. So if it appears that I'm a little unprepared, that's because I am. And it pretty much goes against everything we're going to talk about today. So I apologize for that. I don't actually have any specific qualifications in employment skills or anything like that. That's not my background, but I do have significant experience in employing in my role. I've had a lot to do with employing everyone from students right through to management roles. And I've done a lot of reviewing applications and interviewing, particularly in the last few months, and seem to keep seeing the same mistakes come up that candidates make that are really avoidable. And we discussed this as a board, and we really wanted to give you guys the opportunity to have a think about the way you apply for roles and the way that you interview for roles, because firstly, you want to get a seat at the table. You want to get into that interview room so that you can give yourself an opportunity to tell the people who you are. And then you want to be prepared as possible for that interview and be able to give some really good answers to questions. So the first thing that you really want to ask yourself is, do you want the job? The only way to do that is research. And basically everything that I'm going to be talking about is doing research and preparing yourself. You can look at things, you can go onto organisational websites, department websites, and find out so much information about roles and about organisations. You can look at things like organisational values, make sure that they align with yours. You don't want to work for someone that does not uphold the values that you do. Often, if you know people that work at a place, that's a really good way of finding out information that you're not going to be able to find online, or that you're not going to be able to find from a manager or an interview process. They're not always going to tell you all the things that they don't want you to hear. They're going to tell you the things that they do want you to hear. So it's a really good way of finding out some extra information if you do know people that work where you're applying. Things like pay and conditions can be tricky to ask about, but ultimately, why do we work? We work so that we can get money and pay our bills. It's a really important thing to know about. You want to know how much you're going to get paid for the job that you're going to do. But things like that are really available online. Working in a public healthcare system, all enterprise agreements can be found online. So with a little bit of research, you should be able to find at least ballpark how much you would be being paid. The more you research, the better you're going to be prepared to apply for a role and hopefully interview for a role. So once you've decided that you do want the job, you and you're going to apply, the aim of your application is to get you a seat at the table. You want to be in that room so that you can tell the people about yourself. So typically you'll need a cover letter and a resume, and you want to stand out so that you get an interview. So your cover letter should be specific to the role. Generic cover letters are the worst, particularly if someone's just gone, look, I think this might be a good job, I'm going to apply for it. And then you can see little bits in there that are clearly should have been for a different job. I've had some resumes that I've seen before that have talked about how their aim in life is to be a cardiac physiologist, and that's really what they want to do. I'm like, well, why are you applying for this job then? Like, that's almost an automatic, I don't want to talk to this person. Things that are easily found online that can be brought into things like cover letters are, I spoke about before, values. So at RMH, our values are people first, lead with kindness and excellence together. If you can even think about one of those values, how you uphold that value and how you align with it, and put a little bit about that in your cover letter, that's really going to stand out. That's something that would be really strong to me, that this person wants this job and they've gone and they've done their research. Use specific examples of why you want the job. Your cover letter should show your uniqueness and why you would be better than other people for the job, over and above just your qualifications and experience, and address it correctly. So never write to hiring manager or dear madam, dear sir, because if you're applying for a job, there's a name attached to that job. There's always a name. There's always someone to address it to. Again, that goes back to your research, that you're paying attention to detail in the job that you're applying for. Be concise. It's not an essay. Whilst you do want to include all of the important information and address any key selection criteria that might be in there, and get your messages across, you don't want it to be more than a page. A cover letter should never be more than a page. And you should always get someone to read over your cover letter. The amount of cover letters that I have read that say that someone has really good attention to detail and then had 20 spelling mistakes in it, it's happened so much. So if you're saying that you've got good attention to detail, have good attention to detail and get someone to read that letter for you. A lot of these things are really easy to fix. They're not reliant on your skills or experience. They're just really basic things that you can do really easily and might be the difference between you getting an interview or not. With a resume, obviously you want to include your full name and contact details, and then an opening statement is a really good idea. Just a little bit about yourself, what your goals are, where you've come from in your career, just a short paragraph. You want to prioritize your strong points or your strengths. So it doesn't matter which comes first in a resume when it comes to experience and qualifications. You want to use whichever one is strongest for you. So for example, a new grad would probably use qualifications first, but someone that's been working for 20 years, you're going to use your experience and put your experience first on your resume. Always use reverse chronological order. So your current or your most recent position goes first, because people aren't going to care that I worked at McDonald's in 1997, but they're going to want to know that I'm currently working as a clinical educator at Royal Melbourne. When it comes to qualifications, you don't just have to include university courses. You can include smaller courses, train the trainer, little things that you've done that are over and above things like mandatory training. Every single one of us has done BLS. You don't need to include that. But if you're a BLS trainer and you've done ALS courses, then that's something that you should include. Include any significant achievements and awards, because that's something that will make you stand out. And usually I wouldn't put references in a resume just because you don't want a prospective employer contacting your referees without your knowledge. Maybe they don't know that you're applying for a job and you don't want them to know that about you. But it's good to just acknowledge that you can provide references on request. Make sure that you include all of the important details, but again, you want it to be concise. A 10-page resume is often not going to be looked at in very good detail. So a few pages is all right. And it's really easy to find good templates for a cover letter and a resume both online. So you can just find a template online and copy it and just use the information in there. Congratulations, you got an interview. Before it even starts, there's a lot of things that you can do well that will impress a prospective employer. And one of those is respond in a timely way. So if you're offered an interview, no one's going to expect you to respond in the first 10 minutes, but if you are going to present for that interview, make sure that you respond in the first couple of days. You don't want them to be chasing you to check that you are actually going to turn up. When you do have your interview, obviously presentation is important. So dressing appropriately, turn up on time. If it's virtual, which a lot of interviews are these days for obvious reasons, ensure that you're in an appropriate, quiet location with a really good internet connection. There's nothing more annoying than trying to interview someone and every second word you can't hear because the connection's bad. I'll get into some specific interview questions in a minute, but just some general advice about interviews is that you want to incorporate your research into your answers. One of the best interviews I ever did was for someone, I'm going to say about 12 or 13 years ago. That's how much it stood out for me. That's how good he was. That he came in and he talked about the Royal Melbourne Hospital values and how those values aligned to him and how he lives those values in his life. And I walked out of the interview and I said, well, that's the first person we're employing today. Like, I didn't need to see the other people. He was fabulous. He still works in renal, not with us, but his interview was probably the best I've ever done. And it's because he incorporated the research and the knowledge that he had of the organisation into his answers. Seems like a really silly thing to say, but answer the question. Sometimes people have things in their head that they want to say and they just will try and get it out in any way possible, but you actually want to answer the question that you're being asked. And so listen to the question and give more than one sentence answers. So give a little bit of detail. A good format to follow is circumstance, action and result. So the circumstance of what, a description of the situation, action was what your response was and what you did, and the result detailing the outcome. And though the employer is the one that has the power, it is a two-way conversation. So you want to make sure that the employer is actually right for you, as well as them checking that you're right for them. An important part too is to promote yourself. I have interviewed people that I know that when I've asked certain questions, the answers that they've given have not aligned with what I know about them. They've talked themselves down. I know that we probably all have a little bit of a hard time saying really good things about ourselves, but it's really important to try and do so. That's the point of an interview. So you don't say, I don't have experience in that area. You could say, my experience in that area is minimal, but these are my interest areas and this is what I would like to do to increase my experience. There are some really predictable interview questions. So I'm going to go through a few of those now. They're frequently asked in interview and you can prepare for them. So you don't want to be doing a rote answer that you just know what's in your head, but some of the common questions that you're going to get are tell me a little bit about yourself. You can prepare for that. You want to give your employer thoughts about what's inspired you, why you are where you are, what's brought you to your career at the moment. Why do you want to work here? It's a really good opportunity again to bring your research into the conversation if you haven't had a different opportunity to do so, because the organisational values align really well with mine. I put people first in my work and that will give you a really good basis for standing out. How do you deal with pressure and conflict are both behavioural type questions. They're very common to be asked. And often it's good to give examples of how that you might be asked to give an example, but it's good to give an example anyway of how you deal with these things. What are your weaknesses? It's a good, you need to be truthful, but don't be too truthful. I turn up late for work every day is probably not going to get you the job. But if I gave you an example of myself, one of my biggest weaknesses is I have a hard time saying no, which is probably why I'm standing up here today, because I didn't say no. But you can turn your weaknesses into strengths. So I would say I have a hard time saying no to things, and therefore end up taking on too much work. So I might need assistance with setting boundaries and prioritising. Then the prospective employer can see that you have some awareness of where you don't have strengths, but how you would like to work on them. How do you prioritize tasks and projects? It's another behavioural question. Typically, students will give me answers along the lines of when they had lots of assignments due at the one time. But for clinical staff, it's a good opportunity to talk about when you had a really busy shift and what you prioritised and how you went about it. Where you see yourself in 5 years is one of my favourite questions, especially for students, because it gives you an idea of where they want to be and do they want to be with you. The amount of students that I have say to me, I want to go and study medicine because they think that that's what I want to hear. They think that I want them to be ambitious. I do want them to be ambitious, but I want them to be ambitious as a renal physiologist. So they think that I want them to be ambitious, and therefore it doesn't rule them out, but it doesn't put them on top of my list because I'm looking for a certain thing. I don't want them to tell me the answers that they think I want to hear. I want them to tell me the truth. I want their answers. And you'll always be asked if you have any questions. And it's really important to never say no. You can prepare questions for this. This is a really simple one. Things like, because it is a two-way interview and it has to be right for both parties, you want to ask anything that you do want to know about the organisation, but things like, why do you like working here is a good question that I sometimes get. What opportunities are there for professional development or for me to advance my career? Or what do you think my biggest challenge might be in this role? They give your prospective employer a really good opportunity to have a think about why they think you would fit in. So in summary, just thank you to the bell. Prepare well is probably the best advice. Make sure you do your research for the role and for the organisation. Make sure that the job is right for you. You might decide after the interview that it's not right, and that's absolutely fine, but make sure that you communicate that. Find ways to stand out, might be by your achievements or by your knowledge of the organisation, and control the things that you can control. You're not always going to be able to predict all of the questions and things that might be thrown at you in an interview, but if you prepare yourself and you do the research and you apply well, then the rest of it's out of your hands. Thank you.
Thank you, Kristen, for that very informative session. Because we are running a few minutes over time, maybe individual questions could be asked to Kristen and Rajiv at the end of the session, if they're okay with that. I would like to welcome our next speaker, Aaron Watson from Charles River. He'll present endotoxin testing, EndoSafe and horseshoe crab technology. Aaron Watson is the owner and a senior microbiologist at SC Bio Limited. He has a BSc in microbiology and is responsible for earning accreditation for endotoxin and total viable count testing to ISO 23500 from IANZ. He started supporting dialysis with endotoxin testing in 2008 and since then has become a leader in endotoxin testing in New Zealand, supporting healthcare and life science manufacturing. Please welcome Aaron Watson.
Right, thank you for that introduction. That's very kind. Okay, so today I'm going to be talking about endotoxin testing and dialysis. And I'd like to start off with a video so that you have an understanding of some of the source of the reagents for endotoxin testing. How do we do it? You have volume? Yep.
The Atlantic horseshoe crab, Limulus polyphemus, has long been valued by the biopharmaceutical industry as a source of critical proteins that detect the presence of harmful bacterial endotoxin. Called Limulus amoebocyte lysate, LAL, these proteins come from the animal's blood cells, amoebocytes, and serve as the foundation of the LAL endotoxin test. In the 50 years since its discovery, LAL has proven to be the most sensitive and effective indicator of endotoxin contamination in treatments like vaccines, IV drugs, and medical devices. At least 10 times more sensitive than traditional test methods, LAL can detect as little as half a picogram per milliliter of endotoxin, equivalent to 1 grain of sand in an Olympic-sized pool. Because it is a natural, renewable source of LAL, the horseshoe crab has become the focus of tremendous efforts to preserve and protect this incredible creature. In 1992, IndoSafe founder Dr. James Cooper wrote draft legislation to regulate horseshoe crab fisheries. As a result, South Carolina enacted laws to protect its indigenous crab population. In combination with the efforts of advocacy groups, the laws have served to preserve the animal's natural habitat and prevent their use as bait. South Carolina is now home to 8 island sanctuaries. Conservation efforts have spread to span the eastern seaboard. The Atlantic States Marine Fisheries Commission now mandates that all Atlantic coastal states identify horseshoe crab nesting beaches. Charles River is committed to the conservation of this extraordinary species that contributes to the everyday health and safety of people and animals all over the world. As a responsible manufacturer of LAL, we are proud to play a role in alleviating pressures on the horseshoe crab through active animal welfare campaigns, decades of R&D, and scientific innovation. Each year, our highly controlled and monitored bleeding programs begin with hand collection of crabs, performed by our licensed fishermen in local South Carolina waters. Our technicians practice humane care throughout the health inspection and blood collection processes, and animals are returned to the sea within the same day. Continuing our conservation, we strive to do more with less. We've developed FDA-licensed LAL cartridges that use 20 times less raw material than traditional LAL tests. We are constantly refining our cartridge technology so that responsibility rather than demand can continue to guide our operations. Used in our portable endotoxin testing systems, our LAL cartridges produce point-of-sample results in just 15 minutes. It is critical that we serve as advocates for the humane treatment of horseshoe crabs and strive to achieve balance between our need for this valuable material and the livelihood of the animal that provides it. To learn more about how we are helping safeguard the continued population growth of the horseshoe crab, please visit hsc.criver.com.
Right, just to clarify, I don't work for Charles River. I work for a company in New Zealand called SC Bio Limited, and we distribute the Charles River products here in New Zealand for the detection of endotoxins. And so what are endotoxins? Endotoxins come from gram-negative bacteria, and they cause toxic shock syndrome. So that's why it's important to be able to detect them and ensure that the waters used in dialysis are free. Endotoxins are a component of the cell wall of gram-negative bacteria. And here's a diagram giving you an idea of what it might look like. So with the gram-negative bacteria, we also have another group of bacteria called gram-positive. So there's a process where you can do a gram stain and you get a crystal violet, a purple stain, and you stain bacteria on a microscope slide, and then you wash the stain off with ethanol. And if it sticks to the bacteria, it's gram-positive. And if it gets washed off with the ethanol and you look at it under a microscope, then it's gram-negative. So that's how this phrase comes about, gram-positive and gram-negative. And endotoxins only come from gram-negative bacteria, and they are still biologically active when the bacteria are dead. So that's why you have your microbiology as well as endotoxin testing done together. So how did the decision to do endotoxin testing in water come about? And so there's a study from 1975, or a report, I guess, of an occurrence in the Lancet in 1975, and they talked about an event. There was a drought. The water table went down. Patients in the dialysis clinic started having fevers and dying. And what they found was, because of the drought, the water levels in the water reservoir went down, the nutrient concentration went up, and some cyanobacteria started growing and got into the municipal water supply and into the water that was used in renal dialysis. And so they realized this, they figured out what was happening, they wrote an article about it in the Lancet, and their conclusion from that was not to do endotoxin testing, but was to install reverse osmosis plants in dialysis clinics. Yeah. You guys already know all of that. So in addition to installing a reverse osmosis plant in your dialysis clinics and the water filtration that you have regular monitoring programs for endotoxin testing. And in 2015, a paper was published that, in addition to harmful levels of endotoxin which cause fever and possibly death, you can also have this concept of long-term exposure to small amounts of endotoxin. And in the study, they compared the clinics with a lower detected endotoxin levels in their water with other dialysis clinics that had higher levels, and on average, the all-cause mortality of the patients in the clinics with the lower endotoxin levels was less. So they had more or less a better performing clinic, had better life expectancy as well. That's what endotoxin testing is about. Okay, so when you're reading your standards, you'll see the phrase LAL, Limulus amoebocyte lysate. So what is that? That is the blood from the horseshoe crab in the video. And if you remember, it was blue, so it's quite a little bit different. And so these horseshoe crabs are donors. They donate the blood. They are then released back into the wild afterwards as well. And it's still the most sensitive way to detect endotoxins. And so when you're reading your standards and you see LAL for endotoxin testing, that's what they mean. They mean using the reagent from this animal for the detection. So in our laboratory at SC Bio in New Zealand, we offer endotoxin testing as a service, and we use the cartridge technology talked about here, and also many clinics across New Zealand have their own system for endotoxin testing. What are the limits? So you have this concept of allowable amounts in the water, and so you have different limits depending on the type of water. So you have your RO water, and then your standard dialysis and your ultra pure dialysis, and their corresponding limits that they have. And then in endotoxin testing, there's variability. So what that means is an answer of 2 is the same as an answer of 4. And so we have this idea where the measurement uncertainty of the test is twofold. And so what that means is that you have these action limits, which are 50%, and that's the twofold. So that's divided by 2 and times by 2 for that. So you have action limits of 50%, and that's certainly you see it elsewhere, but certainly in endotoxin testing in the United States Pharmacopoeia, the European Pharmacopoeia, they have these accepted recoveries, which is 50 to 200%. So the action limit of 50% is a good rule, and it reflects the variability in endotoxin testing. It's a good safety parameter. In ISO 23500, it doesn't have an action limit at 50% for ultra pure dialysis. It's not listed. And that might be a reflection of past technologies of endotoxin testing not being as sensitive, but it is possible now to have an endotoxin test that is half of 0.03. So you can specify an action limit at 50% of 0.03. That is possible. Yeah. Testing, so you're going to have a regime, a periodic regime, so you can test monthly on the RO plant is probably the best thing to do. And then once your dialysis machines are shown to be within spec, you can reduce your regime from monthly to something else, depending on your risk assessment for that. So what does LAL stand for? The Limulus amebocyte lysate. So the genus of the animal, amebocyte is the blood cells in the lysate. So they burst them, they spin them down and harvest the components that they need. As mentioned before, the animal survives. They're a blood donor. They're not killed for their blood, and they're released back into the sea. And it's better that way than not being a protected species for this purpose, because prior to that, they were fish bait. So the mortality of being fish bait is 100%. You're definitely going to die getting chopped up to be fish bait, whereas being a blood donor, it's more of a chance that they're going to survive that process. Why? Someone discovered that their blood is extremely sensitive to endotoxins. They were doing some research at the university and started injecting the animals with bacteria and noticed that the blood clotted. Endotoxins are very difficult to remove from water. They're somewhat heat stable. They're resistant, as I mentioned, they're still biologically active when the bacteria are dead, and they're very small, so they're difficult to filter out. So you'll notice on the back of your dialysis machines, you have special filters designed to remove those endotoxins, and in your RO plant, you'll probably have a module designed for removing endotoxins that you wouldn't see in a drinking water scenario. This is what it looks like in the factory. They get a clean, so they're cleaning the shell to help with the removed barnacles, to help with the health of the animals. They're lined up, they have a tail that's tucked in underneath them, and that releases or exposes an area that blood can be taken from. So they have their vascular system is a sponge, and they have a cavity, and they put a needle into the cavity, and gravity drop the blood out, and once the blood stops coming out of the needle, it's done. One bottle is more than one animal. So Charles River manufactures its endotoxin testing reagents in South Carolina, and they participate in community education for schools and children to appreciate the animal and the environment. So LAL is a component from the blood, and it is a collective collection of enzymes for a biological reaction, and it involves a cascade of components of the blood reacting. And in the animal, the outcome is that the blood clots, and in the laboratory, the clotting factor has been removed and replaced with a yellow chromophore. So that's the substrate up there, and we run the kinetic chromogenic method. Okay, so there are different methods for endotoxin testing, and they all use LAL, the reagent. And what you see here is a progression through time. So the initial format was gel clot. They would look in a glass tube at the liquid and see that it clotted, and that was the gel clot, and it was using your eyes, a visual inspection. And then they started putting the reagents onto spectrophotometers in the laboratory. And then you get endpoint chromogenic, kinetic turbidimetric, and kinetic chromogenic methods. So these are methods using laboratory spectrophotometers to measure it, to take away the subjectivity of the human eye. And they also allow for quantitative assays over qualitative assays. The endpoint chromogenic assay used a chemical to stop the reaction, so that's why it's called endpoint. Kinetic turbidimetric uses the same gel clot and a wavelength, the turbidity wavelength, to measure it. And then the most common test these days is the kinetic chromogenic, and the system that we use in our laboratory and the system that we supply to a lot of clinics across New Zealand use the kinetic chromogenic assay, and that looks for a color change over time. And this is the device that does it. So this is a handheld spectrophotometer with a heater and a pump, and then a single-use piece of plastic with the reagents inside it. So the test cartridge, you add your sample to that. It's in the machine, you press go, and within 20 minutes you get your result. It's rapid, it's small, it's easy to use, and it's the most common system in New Zealand for endotoxin testing and dialysis. Thank you very much for listening. Any questions?
Thanks, Adam.
Wow, look at that. It's impressive. Thank you very much. Looks like a Christmas. Yeah, thanks.
Thank you, Adam. I know that many of you will be preparing for interviews better, but please note that Kristen is not recruiting. Yeah. We're going to split for our vascular workshop. So we'll have one hub around this corner and one on that hub. So before we, so group number 1 will be this corner, and number 2 will be that corner. And whoever doesn't have a number, that means they will be either board members or facilitators. So Sujata don't have a number, Rajiv, and all the board members. Board members are welcome to join any group. It's a concurrent.